We are live now, ma'am. Shall I start?
Yes, please.
Shall I start, ma'am?
Yes, please. Yes.
Yes, Pavna, you can go ahead.
Okay.
Give a countdown and then start.
A very good evening, respected all the faculties. Today, I welcome you all on behalf of Corona Remedies Core Connect live webinar to Knowledge, Aptitude and Practice series by AMOGS and the Bengal Obs and Gynae Society on hypertensive disorder of pregnancy. So before going ahead and introducing our all the faculty members, let's start the session with a small prayer.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Now, I would like to welcome our coordinator of today's event as well as the chairperson, Dr. Sita Ramamurthy Pal. Dr. Sita is consultant fetal medicine from Apollo Multispeciality Hospital, Kolkata. She is currently clinical secretary of Bengal Obs and Gynae Society.
Thank you, Bhavna. That should be enough. Thank you so much. We'll go ahead with the program. And,
okay, ma'am. Ma'am, I welcome you to please introduce Dr. Sneha Bhuyar.
Yeah, please. So it gives me a great pleasure to be a coordinator for this wonderful webinar, which is the Knowledge, Attitude and Practice series, where the program director is Dr. Sneha Bhuyar. This is in association with the AMOGS, All Maharashtra Obs and Gynae Society, and our beloved Bengal Obstetric and Gynecological Society, where I'm the honorary treasurer of this society since 2 days. So it is indeed a pleasure to have Dr. Sneha Bhuyar here with us, and an honor for me to introduce her as well. We've known her for many years, a very active Foxian. She is a recipient of multiple awards, as we can see here, International MS Signature Award for Phenomenal Leadership in 2020, Asia GCC Award 2021, Dr. S.N. Malhotra Individual National Award for Outstanding Work in Rural Obstetrics in 2008, Dr. Durusha Distinguished Community Service National Individual Award in 2022, Dr. Anandibai Joshi State Award by the Government of Maharashtra, Lokmat Healthcare Excellence Award in 2020. She's got a huge experience in Obs and Gynae over 30 years, has given multiple talks and orations, and she has been the Breast Committee Foxy chairperson, has actively done many wonderful programs under her tenure, and she has, she's also been the Governor Council member of ICOG 21-22 AMOGS MD Medical Disorders Chair. She's currently off it and conducting wonderful programs, and also a SAFOG Working Group member, founder, president Vidarbha ISOPAB. Most importantly, very good friend, and she's also standing for the post of Vice President Foxy. So requesting everyone to support her, and all yours to take over to conduct the session. Thank you so much.
Thank you so much, dear Dr. Sita, for being a wonderful friend and also a wonderful convener for today's program. A very good evening to all of you. At the outset, I would At the outset, I welcome all of you here for this program. A very good evening, respected Dr. Rajendra Singh Pardesi, President of AMOGS and my mentor in person, Madam Sujata Dalvi, who is busy with the Bharat Yatra and so could not join today. She's the Secretary of AMOGS, Dr. Mosmi De Banerjee, President of BUGS, and Dr. Jaita Chakrabarti, the newly installed Secretary BUGS. Hearty congratulations. Guest of honor for today's program, our dear friends, Dr. Bhaskar Pal, who is the past president of UGS and IHC, and of course, the chair of AICC RCOG, Dr. Kiran Kurtakoti, who is the president-elect of AMOGS. Speaker for today's program, as you have heard, that this is a program purely based on the hypertensive disorders of pregnancy. The speakers very well chosen, Dr. Sita Ramamurthy Pal speaking on screening and prevention of SDP, and Dr. Ashish Mukhopadhyay speaking on the important aspect of antihypertensives, Dr. Basant Mukherjee guiding us on crucial decision about delivery. Madam Mosmide, Dr. Jaita, Dr. Sukanta chairing the sessions, and I'm sure you will be enriched with the subject thoroughly. And my job as a moderator remains only to take you through the case scenario and to implement it. I'm sure amidst experience and the young innovative panelists, it will be a very fruitful discussion with clear take-home messages. I pray God Almighty and seek the blessings of all the respected seniors here, and of course, the best wishes from all dear friends for my candidature as Foxy Vice President from West Zone. With this, I thank and I welcome all of you once again, and I thank the entire team of BOTS and AMOGS once again. I introduce and invite my mentor, Dr. Rajendra Singh Pardesi, who is the president of AMOGS and past vice president of Foxy. And as all of you know, he's a very, very humble and a very genuine person, always guiding all of us. So, sir, we are eagerly waiting for your precious words. Over to you.
Good evening, everybody. Respected Chief Guest, Dr. Bhaskar Pal, Dr. Kiran Kurtakoti, and President BOJS, Dr. Mosumi Banerjee, Dr. Jaita Chakraborty, Dr. Sujata Dalvi, Dr. Sita Pal, Dr. Ashish Mukhopadhyay, Dr. Basant Mukherjee, and Dr. Sukanta Mishra. I'm really feeling proud and honored to be a part of this webinar. It's a joint venture, as Dr. Mosumi told, of AMOGS and Bengal Obstetric and Gynec Society with the dignitaries of BOGS. I'm really happy because Sneha told me, sir, there is a webinar with Bengal Obstetric Society. I told her I am coming because since many days, as Dr. Sukanta told, I wanted to meet Dr. Bhaskar Da, Dr. Ashish, Dr. Basant, Sukanta, Dr. Kanchan, Dr. Sanjeev Da, Dr. Subhash, and all many. So the topics are very nice. Sneha is very active in our AMOGS. Now hypertensive disorders of pregnancy, I don't want to highlight anymore because all stalwarts are there. But still, as upcoming leader, Dr. Bhaskar Pal, Dr. Ashish, just I wish to tell you that eclampsia now maternal mortality has been reduced. It's a 97 now rate of our India. But still, now we cannot admit eclampsia in private because there are too many results, means at least 4 or 5 results of Consumer Protection Act that if you don't have ICU, why you are admitting. And that's why many times even taluka level, the patients are referring to tertiary center, and in that delay, the mortality happens. So please look into this matter, as Bengal Obstetric Society is a vibrant society. So we all collectively, we can fight against this Consumer Protection Act. And due to the Consumer Protection Act, there are many hassles. So the leader will take care of future coming leaders, even Sita Pal also. I wish every success to Dr. Sneha Bhuyar for her future endeavor in Foxy as Vice President Foxy, and wishing every success to this event. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you. And as Madam Sujata Darvi, our Secretary of AMOX, as she is busy with other CME, on-site CME in the South Zone, so she will be missing her message as well. With this, I now request Dr. Moshmi D. Banerjee, who is the newly elected and installed president of Bengal Obscurity Society. Bhavna, can we have Dr. Moshmi CV? Or we can have it at the time of academic session. I just congratulate you and welcome you for this program. Dr. Jaita, who's the secretary, I welcome you. And with this, now I invite the guest of honor for today's program, Dr. Bhaskar Pal, who is a dear friend known to me for so many years. I just said that he's a past president of Bengal Obscurity Society and also the past president of IIG, IICC, ICOG chair, and a very thorough academician, I would say, a very genuine and straightforward person. And Bhaskar, we are very eager to listen to your precious words. Over to you.
Thank you, Sneha. Thank you for the kind invitation. It is a pleasure to be present at this joint meeting of AMOGS and Bengal Obs and Gynae Society. And great to be among friends like Dr. Pardesi, Kiran, and everyone else. It is a pleasure to be invited by Sneha, and I think it is in a few days, I think it's a very important juncture of her life, and which I'm sure that she will pass with flying colors, because many of you do not know. It's easy to sit in Aurangabad or Bengal or Mumbai and think how it's not so difficult to get into Foxy, but Sneha comes from a small society called Yavatmal. And by very hard work over the last 20 years, she's become one of the tall leaders of Foxy. So all the best, Sneha, and I'm sure I have no doubts that you'll come out with flying colors. Hypertensive disorders in pregnancy is very important. We managed to reduce the morbidity and mortality from hypertensive disorders over the past years, essentially by training and dissemination of information, and which doesn't mean that we can let it up. There's still places where we need to reach, and that is why such an webinar is very important. And I think it is an excellent selection of speakers and panelists and moderators and chairpersons. And I'm sure that it will be a good continuing medical experience, educational experience for all of us. Thanks a lot, and I wish you all the best.
Thank you so much, Bhaskar. Your words are always guiding and enriching us with some information. Thank you so much for all your best wishes also. Now I welcome my dear friend, Dr. Kiran Kurtakoti, who is the president-elect of AMOGS. Kiran, I know since so many years. Just formally, yeah, I would. I'm sure Kiran is restless to read this.
Thank you.
I do. Yes. Yes.
Yeah, thank you so much. You can delete this.
Bhavna, please stop sharing. Let me just say he is a dear friend and a wonderful person, always busy with his practice operative sessions as well, but he doesn't, doesn't forget to join the programs for friends as well, and a very good support to me. Over to you, Kiran, for your precious work.
Thank you. Thank you, Sneha. Thank you for bringing AMOGS and Bengal Society together. And definitely to Bengal Society, we will be together in another 2 to 3 years' time. I'm sure when some of you would be at the helm of the affairs, or you desire to be at the helm of the affairs. So thank you. See a lot of good friends. Pardesi sir, namaskar. Mishra sir, namaskar. Banerjee madam, best wishes to you during your tenure. Ashish, very high to you. And Bhaskar is not seen, but anyway, Bhaskar, hi. Dr. Khanam and all. So thank you, Sneha. And as Bhaskar rightly pointed out, Sneha is one such worker or a dedicated worker. I'm seeing Sneha right from our undergraduate days. Like we come from the same alma mater, that is BZ Medical College, Pune. So I've seen her right for the past about say 25 odd years and doing a very pioneering work. And Dr. Pardesi rightly said that we cannot admit eclampsia in our own hospitals for various reasons. And Sneha is doing a very pioneering work in AMOGS. Towards eclampsia-free Maharashtra. This is one of the themes that Dr. Pardesi sir has taken forward with Dr. Gorakh Mandrupkar and all of us. So Sneha is also doing a very good work there. And I would really appreciate your work and today's topics, that is on antihypertensives in pregnancy. So congratulations, best wishes to you. And Bengal Society, please stay close to Maharashtra societies. That's all that I can say. And Sneha, best of wishes to you. And I'm sure that you will succeed in their recent endeavors as far as Fox is concerned. Thank you. Basha, best wishes to you also. Bhaskar, best wishes to you also.
Thank you so much, all the dignitaries, Pardesi sir, Dr. Bhaskar, Dr. Kiran Kurtakoti, all the team Amox and team Bengal. And with this, the blessings of God Almighty and blessings of seniors, we go ahead with the academic session. I hand over the session to you, Dr. Sita. And yes, I think we can go ahead with the first talk.
Thank you. Thank you once again, all the dignitaries. Thank you, Pardesi sir, for joining us. Dr. Kiran for giving your words of wisdom, and Dr. Bhaskar Pal for being the guest of honor. We start our academic session with the first session of 3 talks. So I invite the respected chairpersons. First one is our president, Dr. Maushumi Banerjee, who's a consultant gynecologist at the ESI Hospital, Shialda. She's just taken over as the president of our society, Bengal Obstetric and Gynecological Society. She's also the vice president of IMA Calcutta branch. She has been the organizing secretary of Boxcon.
I think that's all, Shweta. Let's proceed.
And we're eagerly waiting for a great tenure under her leadership for the forthcoming year. Thank you. And the next chairperson is our own honorary secretary, Dr. Joyita Chakravarti. She's a consultant obstetrician and gynecologist at Manipal Hospital, Bellevue, and has taken over the baton of the secretary of our society. She's also the very active managing committee member of IAG Bengal, and she has been the joint treasurer of AICOG of 2023, of the most well-organized AICOG 2023. Thank you. And so the first talk will be mine. So I'll hand over the session to Dr. Maushumi. And yeah. Can I introduce Dr. Shukanta Mishra as well? Or can you just put his slide, please?
Yes, Bhavna. Dr. Sukanta Mishra's CV, please.
Hello.
Okay, Sita, see,
Yeah.
I'm visible.
No. It is my indeed honor and privilege to welcome Dr. Shukanta Mishra, who despite his busy schedule, initially was a bit reluctant because he was busy in the evening, but he's managed to join and in time. He's our past president of our society and professor and head of the very famous Vivekanand Institute of Medical Sciences, Kolkata. He's the founder president of the Bengal chapter of Society of Vaginal Surgeons. He's also the president of the Kolkata chapter of
Leave it. Thank you very much.
Very revered teacher and a guide and a mentor. Thank you, Shukanta, for joining.
Thank you.
Welcome, sir.
So I hand over the session to Dr. Maushumi now to start off with. Yeah.
Yeah.
Yes. So our first talk is on screening and prevention of HDP. And for that, we have our very well-known figure in Foxy, Sheeta Ramurthy Pal, and our honorary treasurer now of our society. So I think you should be introduced, right? Your slide.
Okay. That's fine. The first slide was there.
So over to your talk. Let's hear you.
Thank you, Maushumi. Thank you. And I start off with the first sort of challenge we have in hypertensive disorders of pregnancy, which is of screening and prevention, because we still are seeing such huge numbers and huge increased burden of preeclampsia and eclampsia. And now with the added load of not being able to admit, which I've just heard from Pardesi Singh, so I don't know if that is true for all the other states, but this is will obviously deter our, in terms of shifting the patient once it's been diagnosed to other centers, that so much precious time is going to be lost. So we obviously start with our initial baton of prevention is better than cure, and start off with screening and preventing these disorders. So that's me for you, and thank you again for this opportunity. So right now with the new ISSHP recommendations in 2021, where our own Dr. Sanjay Gupte has been part of the recommendations with Laura Maggie, The definition is where hypertension is defined as systolic BP of more than 140 and or diastolic of 90, based on an average of at least 2 measurements, where we all know it's a multisystemic disorder where it originates in early pregnancy, and it involves both maternal, fetal, and placental factors. And the recent incidence is about 10.3% in India, which still is the second leading cause of maternal mortality worldwide. And the main problem is because of its atypical presentations, which often causes dilemma. Again, sharing with you the new recommendations of 2021, where the latest, I'm not going into the details, but what it says about preeclampsia, where it's accompanied by one or more following new onset conditions at more than 20 weeks. So apart from what we already had, what is included is the uteroplacental dysfunction. So it's one or more of the following. So if a patient has a placental abruption, a fetal growth restriction, or abnormal Dopplers or IUD, this will also be included in your definition of preeclampsia. So the clinical classification still remains the same as to be say early onset, where it starts before 34 weeks or manifested before 30 weeks, where the 34 weeks where the maternal complications are much more severe, and with consequent effects also on the fetus being more severe. Where the late onset is onset of proteinuric, may not be proteinuric after 34 weeks, but the maternal complications are obviously generally less severe. So this is a disease of the vascular endothelium, and that's why we are targeting a screening of those factors where the baseline hyperstimulation state might be there, which is the pregnancy itself. For the woman who has a predisposition already, she has to develop these diseases with an additional insult of an anomalous placentation that aggravates the whole disease and makes it worse for the woman. So the root causes are, we say, it's the maldevelopment of the placental vasculature with a consequencing damage to the endothelium, which causes adverse effects on the mother and the fetus. And there's a growing body of evidence that shows that it's the maternal cardiovascular system that has a significant contribution to the disorder. And so we are shifting our focus to the maternal status pre-pregnancy and post-pregnancy in terms of non-communicable diseases. So the basis of all these screening methods is, that has been identified, as they have said, is that a combination of tests, because a multitude of factors work in the etiopathogenesis, the multitude of combination of tests and patient characteristics works better, because as we know, it's heterogeneous and it's reflected better with two or more different markers that we use along with the patient characteristics. So what are the strategies that we can use? They are the clinical history and maternal characteristics, where we still fall short because we don't do a thorough job. And then we fall back on biophysical and biochemical markers like mean arterial pressure, which we'll be knowing about it, uterine artery Dopplers if it's available, biomarkers still if it's possible, and then the new ones, new kids on the block. Now, these are again the risk factors that have been classified recently in terms of the moderate risk factors and as high risk factors, where you have the prior pregnancy history, where the most, like a previous preterm, a prior preeclampsia is a high risk factor. But if she has two or more of the moderate risk factors, which also shows about different demographics, pre-existing medical conditions which are on the high rise because of increasing maternal age, and all this increases our risk automatically of all these women developing hypertensive disorders. But unfortunately, when we look at the maternal characteristics per se, there's an insufficient tool for an effective prediction, where the detection rate of early preeclampsia is only 40% and late of 30% for a large false positive rate of 10%, which is obviously not very acceptable. So here comes our HTP gestosis score, which was started in 2019 by the gestosis group, and where Dr. Sanjay Gupte and the entire team is involved, where this score involves a very easy score, can be done in the outpatient setting. Again, it relies on the maternal history factors like the NICE, but the difference is that each score is allotted 1, 2, 3 as per the risk factor, and with a careful history, you sort of develop a total score. But the most important thing about this is it considers each factor as of equal significance. So it gives weightage according to the severity, and it's more of a dynamic thing. Every time the patient comes in, you can sort of reassess and see what her score is now, whether she has, the risk has increased or not. So this is a very useful gestosis score, which has been used, and there is an app as well where you can download and use it. Assessment of proteinuria has been a time-tested measure, but significant proteinuria we know is greater than 300 milligram, but we also know that no proteinuria does not rule out PE, and that is very important to remember. So it is one of our methods that we have as a complement to our other factors, but not totally reliable on. Mean arterial pressure is a measure, is ideally, if we are going to use this as a screening method, not just the ones we typically use, but if you're going to use it as a screening method as part of a screening protocol, we have to using an automated BFeed device, which is validated in a sitting position with the patient's arm at the level of the right arm of the heart, use an appropriately sized cuff, which is very important, and measured in both arms simultaneously with 2 sets of recordings, which are made at 1 minute intervals. So these are issues, it can be done with the proper training, but there's always a shortage of staff. But I think this is something, if we do properly, can go a long way in screening and preventing the disorder. So average of 2 measurements have to be taken, which is converted to moms in the software. So when you're using maternal history and mean arterial pressure, the detection rate increases to 76% for a still of a false positive rate of 10%. But again, all for early onset preeclampsia, which was figured by the group of Leonapone in 2011. Now, uterine artery, again, the basis, we all know that the stage of remodeling occurs, which we have learned. And so we use it as, because all the placentas of patients correlate with the abnormal uterine artery waveforms. And here we use a color flow mapping. When we use the first trimester screening, we screen for the uterine artery Dopplers. We no longer consider the diastolic notch, even if it is there or not there, doesn't mean that the patient is high risk or low risk. You calculate the PI of each uterine artery of each side, and then the mean PI is calculated, and if it's above the 95th centile, the patient is categorized as high risk. Even if it is in the first trimester, or even if it's in the second trimester, the uterine artery PIs are of equal importance. The only difference is the prevention might be early, or if it is detected in the first trimester, it has its equal importance in the second trimester also. So in the first trimester, your mean PI will be around, 95th is about 2.35, and in the second trimester, it's about 1.4, either transvaginal or transabdominal you can use. You can also use it in the third trimester to predict the outcomes. So if it is high in the third trimester for a growth-restricted fetus, it also means that this baby is going to have an abnormal adverse outcome. So it doesn't mean only for diagnosis, it's also for prognosis. So if you screen by the first uterine artery PI, where ISOOC says it's 48% women will develop early PE, and 26 for late PE. So as you can see, all of them do better for early PE rather than any PE, and it's all for a 10% screen positive rate, which is again something which we need to consider so that we can have markers with a less positive rate, so that we don't tend to interfere more or intervene more for the false positive groups. Next, we come to the biochemical markers, which some of them are used as part of our aneuploidy screening. So one is PAPA, which is a large glycosylated protein, and low levels are associated with higher incidence of PE, which helps in the detection rate of 16% and 8% false positive rate to predict PE. So you can use first trimester PAPA, and when you combine it with the second trimester biochemical markers, they have said that they can predict late onset PE. And a lot of the studies nowadays are focusing on these biochemical markers if available, because the late onset PE is something which we need to target at, because the early onset is more easily detectable and manageable, rather manageable as in terms of following them up. Placental growth factor is the member of the vascular endothelial growth factor, where you see it is reduces in the second and third trimesters in those who develop preeclampsia. So it has a detection rate of 55% for early and 33% for late. Next, anti-angiogenic marker is the S-slit, soluble FMS-like tyrosine kinase, where the levels increase 5 weeks prior to the onset of PE. So this has its importance, where you can do the test and then see if the lady is going to develop. And you can also do a ratio of S-slit PLGF, where it has a detection rate of a good 88% for a 10% false positive rate. So here it adds the value in progressive disease, where you can see if the lady is actually going to develop, and then you can modulate your measures to prevent adverse outcomes. So this is in a nutshell, where you have your biophysical and biochemical markers, what happens to them, and you put all this and see in your protocol, and this is a competing risk model by the Nicolaides group, where they have very successfully shown that if you use all these parameters to detect early preeclampsia, it's almost to the range of 100%, but it goes down to 80% of less than 37. So this was a very landmark trial where they also combined, where they compared it with the NICE guidelines, and they said that this does very well when you use it with all the other markers, provided they are available and at your disposal. So in the first trimester, if you use the maternal characteristics, mean arterial pressure, and which is actually called the triple test in the first trimester, and this will be your prediction model, where in terms of maternal factors, this is a detection rate, and it increases to a good almost 95 to almost 100%, as they said, when you use the entire triple test, and that is what the FIGO recommends. And this was a recent systematic review published last month, in June 2023, where it looked at do first trimester screening algorithms reduce the prevalence of preterm preeclampsia. They agreed to what was studied, and they said they can reduce with aspirin. The effect is most marked for the prevention of preeclampsia resulting in birth less than 32 to 34 weeks. So introduction across a variety of healthcare settings is both feasible and efficacious, and that has to be seen what can be done in our country. In the second and third trimester, as I've said, we look at decreased PLGF levels, and that is available, S-split and PLGF ratios. So testing is applicable to confirm clinical suspicion with symptomatic women after 20 weeks of gestation. But you must know that decisions are not solely based on these markers. You have to put the entire picture in perspective and take in context the other clinical signs and symptoms. So this was a study looking at the S-split PLGF ratio, which was published way back in 2016. And they also said that it's elevated before the onset of preeclampsia, and the ratio of less than 38 can be used to predict the short-term absence, which means that the negative predictive value was better than actually predicting the positive aspect of it. So ratio of 38 or lower has value in predicting the absence of adverse maternal or fetal outcomes within 1 week. So if it's available, it's has a good negative predictive value. This was again a pilot trial which showed that the availability of PLGF improves your detection rate or screening rate, and it improves the outcomes. So all this input into perspective came the FIGO guideline in 2019, and they said that if you use the risk calculators where your cutoff is 1 in 100, it is most predictive of early preeclampsia up to the range of 90%, and the calculator is actually available free of charge where you can download. But they have also looked at the low resource setting models, and they have said that if you can't measure your biochemical markers, your baseline screening test with maternal factors and mean arterial pressure can be done, but just don't rely on the maternal risk factors alone. And the same thing can be used for twin pregnancies also. And you can use the PAPE by itself, which you're already using for our aneuploidy screening. And this can improve your screening, even if you don't have your other PLGF markers. So this is what they have said in terms of low resource setting, where the total population undergoes a first stage screening, and then if they're positive, they undergo a second stage screening if you have by PLGF and uterine artery PI. So this is the FMF calculator, which is downloadable, and you can put these characteristics. You can have it just in your phone, and you can use it. And the latest kid on the block is the use of ophthalmic artery Doppler, still being evaluated. That it is because of the maternal demographic characteristics, as we have said, that those are causing problems. It is the maternal characteristics. So here we can find out those by doing ophthalmic artery Dopplers, which is recording of medical history and velocity of the waveforms from the maternal ophthalmic artery. I'm not going into the details, but it's just that the detection rate was 50% when 4 measurements were used. It seems elaborate, but when it is done, it is quite easy. So this is something which we have to watch the space for more data on it. The new markers that have come up is the Congo Red, which is being very widely used. In fact, Dr. Gupte the other day was mentioning about it, where they have a very easy method of identifying women, which is a 1-point bedside test, or a urine test, which identifies misfolded proteins. So basically, you can use your biomarkers from placenta, endothelium, and organ involved, and you can use these endoglin placental RNAs, mRNAs, which can detect, and this is also the space that we have to watch for. So what are the preventive strategies? One, you have screened them and identified. Primary is obviously modifying lifestyle. Secondary is interruption of the pathology. And obviously to prevent complications would be your tertiary prevention. Again, I'm going back to your ISSHP recommendations where they have said that unless there are contraindications, all women should exercise. So even for these women, you must ask them to exercise because that reduces the likelihood of gestational hypertension. They should do around 140 minutes per week, with an intake of calcium being adequate, a calcium supplementation of 500 milligram per day, and they should not receive all these just for preeclampsia prevention, like low molecular weight, vitamin C or folic acid only for preeclampsia prevention. Following this, the first trimester screening, the Aspirate trial very conclusively said that you can use 150 milligram of aspirin in the first trimester from 16 weeks onwards to be taken at bedtime until 36 weeks or earlier when delivery occurs or when PE is diagnosed. So that has it shows an 82% drop in the rate of early PET and 62% in the drop of preterm preeclampsia. So again, going to the international ISSP recommendations, that low-dose aspirin to be taken at bedtime, preferably before 16 weeks and discontinued by 36 weeks, sorry. Aspirin should be given at a dose, if you have done your multivariable screening, should be taken at 150, because aspirin at a dose of less than 100 is not recommended because based on the platelet insensitivity to aspirin up to 40% of women, especially because as the pregnancy progresses and the BMI increases. So less than 100 is usually not recommended. However, though we say that the convincing evidence is strongest with therapy prior to 16 weeks, some of the studies, especially one study in 2019, say that incidence of PE may still be positively influenced when aspirin is initiated, and given its safety profile, debatable, high-risk women who present for antenatal care may still benefit from prophylaxis. I think a lot, many people are doing it, but we don't know how much is it. So this study did say that, and this aspect has been and controversially debated in the literature. But obviously, we know that it is better when started early. Again, routine, does that mean that we should be offered to all women? No, it shouldn't, because in a study was done, said that a lot of them declined the randomization, and it has its other effects as well. And this daily aspirin did not decrease incidence of preeclampsia when compared to placebo, and adherence to treatment was only abysmal 48%. Other issues with chronic hypertension, you can, a subgroup of the Aspirate trial said that may not decrease, but because aspirin is safe and confirmation is lacking, they it says should still be offered. And vaginal spotting, please do not stop the aspirin. So we all know that the prediction is still low because the presentation is variable. Lab studies are variable depending on what lab we use and has to be standardized. Maternal populations that we see are variable. So, and the most strategies that we see, they work in small populations. We have to use what we have with us. So the key points is that the ideal screening method, we all know based on what available evidence we have, is the use of the multivariate analysis to calculate the risk. And based on that risk, we can start them on 150 milligram before 16 weeks. And it has considered safe and tolerable. But given the lack of data, we should not be universally prescribing them. Calcium supplementation is beneficial, also adding the role of exercise, and look for the risk factors. Thank you so much for your patient hearing.
Thank you, Shita. It was a wonderful presentation. You have covered all the corners with so many new informations. Now, may I ask Shukantada if you have any comments?
Anybody can comment, not only
Yeah.
one.
No, the co-chairperson I was asking for.
Sure.
Chairpersons of this.
Yes.
Thank you, Mosumi. As a matter of fact, I feel very much privileged to be here in this group among so many stars, I would say. And who else can discuss this screening and prevention other than Sita? It is definitely wonderful. I was looking for some of the things, what you said, all in the ideal situation. But in a country like ours, the early onset preeclampsia causes more of problems. We fail to diagnose earlier. And late onset preeclampsia, we cannot anticipate. So basically, both the groups are at risk. But is the early onset? And what should be the practical, pragmatic recommendations that can be utilized in each corner of the country? And then probably as this was suggesting, that we could probably reduce the transfer from a remote center to a tertiary care center, where we cannot admit the patient because of lack of bed or whatever.
Yeah. So I think it boils down to very detailed history taking and, taking the demographics of the patient and using the scores that we have, the whatever score you use. I mean, as long as you use
Gestosis score, I think, has got
SCP
an immense role.
Gestosis score, and then you sort of a dynamic evaluation, triage the patients there. And a lot of us are doing the uterine artery PI. So even if you just base your characteristics on the on the uterine artery PI, which gives you a risk on the report itself, and then triage them accordingly. I think that is what we
So
still
basically, it boils down to history taking, and MAPs are possible.
Yeah,
And if you
that
follow
is
again
something I think we need to work on. We're not doing
Yes.
it diligently. We need to work on and be more, we need more staff. Obviously, that is something. But if you do that properly, I'm sure we'll get a lot more than we normally pick up.
Right. Thank you very much.
If anybody wants to add on, because I missed the Gestosis conference, if there is anything new in that, I don't know. Dr. Sneha can itself say, or Dr. Ashish.
Yeah, you cannot miss anything because it's a very exhaustive lecture and a whole lot of information that you have collected together, all evidence-based. It's an excellent lecture. I mean, it's not just a lecture. It should be a session. It's altogether a session or a
Actually,
this is such a difficult topic, and you have made it so simple. You made it thorough, and
to cover this comprehensive topic in 20 minutes is a hell of a job. And you could do that.
You haven't got tired. Have a glass of water, please.
Wonderful.
Awesome information. Thank you so much.
Yeah, I think apart from this endogene and all those, research which are not of any practical use at present, at least, and they are not commercially available also for testing. So I don't think that it needs to be discussed at this point of time. And you have discussed all the screening tests and predictions and preventive whatever efforts we can do. I think you have discussed very well. Thank you, Sita.
Thank you. So we move on to the next talk, and Joyita, can you please introduce Ashish? Bhavna, can we please have the CV?
Bhavna, can we have the CV? Yes. Thank you.
Good evening, everybody, and it's my really privilege and it's a proud moment to introduce Professor Ashish Kumar Mukhopadhyay. Actually, he really doesn't need any introduction. He's quite a known figure in FOXI, and he was our past president of BOGS, and he was also the vice president of FOXI. And it would be a wonderful opportunity to hear from you, Ashishda, about the antihypertensives. Over to you.
Thank you, Joyita, for that excellent and sweet and short introduction. I liked it very much. It should be a model now. Now, there are 3 questions which you usually make. Can you off this slide, please, so that I can share my screen? Can you see my screen now?
No,
not
we can.
Not yet.
No, we can see
Not
you.
yet.
Okay.
Your beautiful face.
Now the things have improved, right?
Yes, we can see now. Just make it.
Now, please make it full screen.
Yeah, I will. Thank you, Shukantada and everybody, and Sneha. It is a lovely program organized by you. All kudos go to you. And I think that this is one topic which you can discuss on and on and on. And even if you make 1,000 CMEs, it won't be complete, in any way. Sita's talk was one such example. However, I will try to keep myself a short and very practical, or rather simplistic view of antihypertensives. But before going into antihypertensives, I need to say some few words. So I will take maybe taking a bit 5 minutes or something like that more. Now, well, when we talk about hypertension in pregnancy, it's a fairly straightforward term. systolic blood pressure more than equal to 140 or diastolic blood pressure more than equal to 90 millimeter mercury constitutes hypertension in pregnancy, and all of us know that. And any one of them is enough. But when we talk about hypertensive disorders in pregnancy, the entirely situation changes. It's a completely different ballgame. And gradually we progress from a simple hypertension or rise of blood pressure to a systemic disorder, rather multi-systemic disorder with fatal consequences very often. And I don't agree that this incidence of this thing, prevalence has decreased. I rather say that it has increased, only the complications have decreased. Yes, eclampsia has decreased, we agree with that, but then all because of the good clinical management and whatever prevention techniques that we are adopting today. And all of us actually adopting some prevention techniques to all our patients, because this is so common. It becomes easier to manage in a second gravida than a primary gravida, obviously. Now, why is it a real challenge to manage this HTP? The first is because the diagnosis is often missed. And even if the diagnosis is done, course is unpredictable and severity is underestimated. And doctors are very well known for underestimating these things. Improper use of antihypertensives even today is quite common, and substandard care will lead to serious complications that we know. And then development of serious complications, preeclampsia in the early gestation poses a real challenge. So these are the challenging points of HDP as of today. Now, with that back in mind, we'll go back to 2012-13 when it is called the watershed line or watershed year of diagnosis of preeclampsia, when ACOG printed this white paper on the hypertension in pregnancy, and it was 2013 and published in Obsgynecol 2013. And here everything you can see, if you come from top to bottom, you'll see that the blood pressure and proteinuria fairly remain the same. We all know the blood pressure levels, which makes it mild and severe. I'm coming to that a bit later. And proteinuria also greater than or equal to 300 milligram per 24-hour urine collection, or this amount extrapolated to a time collection, or a protein creatinine ratio of greater than equal to 0.3, or a dipstick reading of 1+, beyond 1+, actually used only if the other quantitative methods are not available. Then one thing has changed the entire situation, and that is this word, small word, or. Or means, I have encircled it with the red, or means this is no longer necessary or mandatory. So in the absence of proteinuria, even if we have new onset hypertension with the new onset of any one of the following of the 5 things, any one of the features is there, you diagnose it as preeclampsia. And one of them was the most important, thrombocytopenia, which is a platelet count less than 1 lakh and not the gestational hypertension, a gestational thrombocytopenia limit of 1.5 lakhs. Then renal insufficiency, which is marked by a serum creatinine concentrations greater than 1.1 milligram per deciliter. Mind you, uric acid has no role to play over here. Then impaired liver function like elevated transaminases more than twice the normal, and then pulmonary edema and cerebral or visual symptoms. So all these, or any one of these things, even in absence of proteinuria, will mark a case of severe preeclampsia. So that is more or less accepted everywhere. No wonder then that in 2019, RCOG came out and said that enough is enough. We have to have a different classification, severity classification of preeclampsia, apart from the early and late onset preeclampsia. And the new classification is, in the new classification, we have replaced the mild term into the non-severe term, because many mild terms has given us dhoka and gone into fatal reactions, fatal complications. So now the severity classification is non-severe and severe. However, the blood pressure level remains the same, 140 upon 90 to 159 upon 109, that is non-severe, and 160 by 110 and above is severe, which used to be. And the moderate is gone long ago, so we are not going to discuss about the moderate anymore here. But coming to that, as you saw, that this classification is entirely based on measuring the blood pressure in pregnancy. And this is no mean task. I really mean it. When I see the blood pressure of a patient in our OPD, I'm in government hospitals, the job of measuring blood pressure is usually delegated to an intern, the junior most person in the team, and who is not completely aware of the ups and falls of the blood pressure and which position, etc., etc. So he needs to be instructed very well about taking the blood pressure, which should be in the sitting position, and measured in the left lateral position should be avoided. Even in the OPD, IPD also, you should take the blood pressure in the sitting position on the dependent arm. Now look at the prerequisites for blood pressure measurement. I'd like to comment on this because this is hardly practicable in a busy OPD. I wonder how many of you can do that. That's anybody's guess. The bladder should be empty. There should be a quiet environment in a comfortable room. Now imagine how much of that is practicable in a busy OPD. Patient in sitting position with no crossing of legs, that is manageable. No tight clothing on arm or forearm. No anxiety, stress, or pain, which is difficult to maintain because there is something called white coat hypertension. As soon as she sees a doctor, her blood pressure rises. And patients should stay silent prior to and during the procedure. This is by and large the most difficult thing to maintain because all our patients are ladies. And there should be no caffeine, smoking, or nicotine in the preceding 15 to 30 minutes, and no nasal decongestant or eye drops should be. That is also manageable. The second controversy is about whether we should take the Korotkov sound, Korotkov 5 or Korotkov 4. Now, this is also settled because we all know that the Korotkov 5 is closer to the actual and intra-arterial pressure, and therefore we should insist on the Korotkov 5 sound. But in 5% of women, you will see that the diastolic reaches zero almost. Diastolic cannot be zero. So what do you do in these cases? You just reinflate the cuff and then let it go down and now catch the K4 or the fourth Korotkov sound, and that is the diastolic pressure. So this happens only in 5% of cases, but is worth remembering this. Now, on the third point about the blood pressure measurement is the blood pressure equipment. Now, if you look at the blood pressure equipments, of the three versions, the first one is already out because the mercury sphygmomanometer is banned by the pollution control of India, and which is active now in many states of country, including our state also. So you have to depend on the Android device or an automated machine. Now, Android devices require a lot of standardization, and so therefore not popular, and they give erroneous results. So in our system, we have replaced it with the automated machine or an oscillometer. Now, which is inherently, unpredictable and irregular in its making to finishing results. So I think that you have to now depend on the automated machine, and that is the reason why there are two things that are coming up. One is the patient now measures the blood pressure at home, which is known as the SMBP, the self-monitored blood pressure at home, which is a highly practicable solution. Once you come to the management of antenatal management of hypertension in pregnancy, we will come to that later. And also the doctor uses the same instrument, so she doesn't need to come to the hospital just for the blood pressure checkup. So that is one advantage that we have now. Now, when do you admit the patient to hospital? Now, in case of severe hypertension, severe 160 by 110 and more, it is easy. You can admit instantly, but it will be difficult for admitting 140 upon 90 to 159 by 109, particularly when the blood pressure is not consistent and only once seen. But I suggest that they should be admitted in a daycare unit where you can do a full evaluation according to prediction models. These prediction models are not very running in our country, but we can easily do some maternal and fetal evaluation and then later go in the evening, and that way you save a lot of time and money. Now, how frequently will you check the blood pressure? But this is also very important because, as I said, it is not possible for the woman to come to the hospital regularly, twice a week or something like that. So the blood pressure measurement should be every 48 hours and more frequently if the woman is admitted. And in severe cases, you need to check her up at 15 to 30 minutes until the blood pressure is less than 160 upon 110, and then at least 4 times a day. So you reduce the frequency of checking the blood pressure, and when it becomes less than 150 by 90 also, they need to check her up twice daily. So that should be the protocol. That's what we are following successfully over the last few years in our hospital. Now, before going into the actual subject, we'll discuss about proteinuria also, because this is very extremely significant, as I said at the outset, that proteinuria is no longer necessary for the diagnosis of preeclampsia. But yes, proteinuria must be interpreted in the context of a full clinical review. So alone proteinuria is not at all any indication of any severity of the disease or the diagnosis of the disease also. And use an automated reagent strip reading device, which is also very, very useful and predictable. If dipstick screening is positive, 1+ or more, use protein creatinine ratio to quantify proteinuria. That's a quantification test. And do not use first morning urine void to quantify proteinuria. That is a 2019 recommendation also. And do not routinely use 24-hour urine collection to quantify. So first morning urine and the 24-hour urine collection are gone out of the window, because that way you have saved a lot of sufferings to the woman. Now, in hypertension, now we're entering into the subject, we'll see that there are certain changes which happen before the hypertension is developed. One is the increased sensitivity to the vasopressors. Second is a reduced plasma volume or hemoconcentration, then altered renal function and activation of a coagulation system. Therefore, the hypertension is not central to the pathogenesis of the preeclampsia. So therefore, the immediate question rises, then what is the role of antihypertensives in hypertensive disorder in pregnancy? The aim of therapy is to stop the rise of blood pressure and achieve a moderate fall, but not to normalize it. So never try to make it 120 upon 80 or 110 by 70. But you face some challenges in the treatment of hypertensive disorder. One is that you have predictable response of blood pressure with no abrupt fall in blood pressure, because quite a lot of antihypertensives will cause a sudden fall of blood pressure, causing a lot of problems. And it should be safe to use in a non-severe and severe PIH, rather HDP, and safe to use in all trimesters of pregnancy. That is also important. But it should not alter hepatic and renal function in mother. And most of the in vogue antihypertensives will have hepatic disturbances. And it should not affect the cardiac output or heart rate in mother and affect the uteroplacental blood flow. So such an idealistic antihypertensive thing doesn't happen in the market. But we should know what are the maternal sequelae of a severe hypertension. Why are we prescribing this? We are basically preventing this maternal sequelae. So you should know that one is cerebrovascular accident, two is convulsions, number three is occipital lobe blindness, pulmonary edema, renal failure, liver failure and liver rupture, and deep venous thrombosis. All these and a lot more, but there are certain problems here also, because I wonder how much convulsion prevention you can do by prescribing antihypertensive. So the main point is that whenever you want to prescribe an antihypertensive, think twice or thrice, whether are you doing any good to the patient, or in the name of making good, you're doing more harm to the patient. But this sequelae invariably happens in cases of hypertension inside the body. One is the overzealous blood pressure control. If you do, then there is placental hyperperfusion, and the blood flow is not auto-regulated, and there is compromised fetus. So you need to avoid that. Before going into the antihypertensive, I want to remember a few things. One is that all antihypertensive drugs cross the placenta. We should remember this. Then inadequate RCTs of about this antihypertensives with the one drug with another. There are a lot of RCTs are there, but neither are they reliable, nor they are well made, and the numbers are not good. Data regarding both comparative efficacy and improving pregnancy outcome and fetal safety are inadequate for almost all antihypertensive drugs. The third question is when to start the antihypertensive. 2010, NICE recommended, and also our FOXI recommended, that considering different international guidelines for the treatment of hypertension in pregnancy, it seems reasonable to conclude that a systolic blood pressure of 150 and diastolic of more than 100 warrants therapy. That was the recommendation in 2010. Then came many trials, including the most prominent one of that was the chronic hypertension in pregnancy trial, or the CHIPS trial by Laura Maggie, which actually made some changes. It was published in NEJM in 2015, but it took 4 years for the Royal College to change its level of blood pressure to start the hypertension. 140/90 is now the standard blood pressure level in which we start the antihypertensive therapy, and not 160/110, which the ACOG still recommends, and nor it is 150/100. So I think offer pharmacological treatment, and is wise also. Previously, we used to be very much bothered about the fetal effect, but it has been proved to be wrong. So what are the therapeutic goals or aims for blood pressure levels? And NICE guidelines I'll follow here, and they say it is 135/85 millimeter mercury. There are many levels which are also acceptable, equally acceptable, many levels like 126/80, 130/90, etc., many levels. But I think 135/85 we should accept. What would be the first line of antihypertensive about its drugs and dose? Here, I think I will recommend, before prescribing the antihypertensive, what is an ideal antihypertensive? Is it available in the market? It should be available in oral forms. It should have first onset of action. It should have lack of excessive hypotensive effects. and no acute fetal distress. Obviously, nothing of this kind exists in the market, but we have to agree that we have to treat these women with this medical care only. There is no other alternative. So it remains the mainstay of treatment. The objective is to prevent the woman from dangerously high blood pressure, rather escalating levels of hypertension with its consequent damage on the system, and to permit safe continuation of pregnancy, fetal growth, and maturation. There are many drugs with different classes available in the market. Just few of them: central alpha agonists like methyl dopa, beta blockers like atenolol and metoprolol, and then alpha and beta blockers combined is labetalol. We'll discuss it in detail. Calcium channel blockers like nifedipine, diuretics like furosemide, these loop diuretics, and also the direct vasodilators like hydrolysine. Now, there are certain limitations of this drug treatment, but there should be a positive sequence as exemplified by NICE guidelines in 2019. And here it is for you. Consider labetalol to treat chronic hypertension in pregnant women. This is the recommendation that I'm reading out. Consider nifedipine for women in whom labetalol is not suitable, or methyl dopa if both labetalol and nifedipine are not suitable. I wonder whether methyl dopa you are getting out in the market, but that is the order that they have suggested. Base the choice on any pre-existing treatment, side effect profiles, risks, including side fetal effects, and the woman's preferences as well. If a woman has taken methyl dopa to treat chronic hypertension during pregnancy, stop within 2 days after birth and change to an alternative antihypertensive treatment. That is their recommendation. And reduce antihypertensive treatment if their blood pressure falls below 130/80 millimeter mercury, previously which was not there, but this is now included in the new guideline. So I think you should remember all these things. Now, of course, there are certain limitations of the drug treatment. All of us know that. Just to reiterate, alpha-methyl dopa has got its own problem, causing excessive lethargy in the mother, increased sodium retention, and decreased GFR. It also causes hemolytic anemia and hepatic damage. Then fetal changes like hypertension, smaller HC or head circumference, sleeping disorders in the childhood, etc. Beta blockers are well known for this, although this is the preferred drug. Labetalol is a combined beta blocker and alpha blocker. In experimental models also, they suggested that it's much better drug, but it has adverse effect on the fetal circulation and also causes bronchoconstriction. And the calcium channel blockers have maternal tachycardia, palpitations, headache, etc. Magnesium sulfate is interactive, but it is not contraindicated. Neuromuscular blockage is reported, and circulatory collapse may happen. Vasodilators like hydrolysine dioxide, unpredictable response with possibility of abrupt falls in blood pressure. It causes potential reduction in placental blood flow and causing fetal distress and unsuitable for long-term monotherapy. So you cannot use these drugs for a long time. So chronic treatment is not possible. Now, that is the reason why most of the international agencies and journals, publications, and studies have recommended labetalol as a first line of antihypertensive therapy. There are other second-line antihypertensive drugs, of course, in preeclampsia, but they are rarely used or sporadically used because, they are of maternal and fetal effects. Nitroprusside, nitroglycerin, diuretics should not be used. Many people believe that during pregnancy, do not use diuretics, as it compromises the placental perfusion, and only used to treat pulmonary edema and heart failure. There are only 2 indications for using diuretics in my mind. Angiotensin receptor blockers, ACE inhibitors should not be used during pregnancy, contraindicated. Metoprolol, beta-1 selective blocker, and pindolol like beta blocker with intrinsic sympathomimetic activity in order to raise the cardiac output, they are considered acceptable alternatives, but they are very, very rarely used because we do not have much study, much data. Beta blockers like atenolol and propranolol are also not recommended in pregnancy. So we have only 2 or 3 drugs in our hand, and labetalol, this is the top one of them. It is an antihypertensive drug with a selective competitive alpha-1 adrenergic blocking and non-selective competitive beta-adrenergic blocking activity. The blocking activity alpha-beta is 3:3. 2 ml injection is available. Each ml contains 5 milligrams of the drug. Now, these are the responses which you get from the norepinephrine release from the different receptors. Heart, as you know, has got beta-1 and beta-2, and the arterioles have alpha-1 and beta-1, and kidney has beta-2. So beta-1, sorry. So all these responses are coming from the receptors, and a part of it, that the labetalol is engaged into working in the arterioles level, also kidney and heart level, in improving the cardiac output. That is why it is so good to be used. But it's a salicylamide derivative, antihypertensive drug, oral as well as IV is available, and the mechanism of action is quite good. The pharmacokinetics says that the peak effects happen in 2 to 4 hours, and plasma half-life is 6 to 8 hours. But it is shown to cross placental barrier like all antihypertensive do. Adverse effects we must remember before prescribing labetalol, and we do not see much adverse effect with the labetalol except the nasal congestion. But the contraindication should be the any heart block beyond first degree, second or third degree heart block is a contraindication. History of wheezing or asthma is a definite contraindication. Cardiogenic shock and bradycardia is a contraindication, and hypersensitivity, of course, is there. So you just follow the pulse rate or the heart rate, and you can prescribe in a healthy woman with labetalol after doing a liver function test. And this is the regime usually we follow for the IV labetalol, which is also used for severe hypertension and also hypertensive crisis. And starting with 20 milligrams, some people start with 10 milligram and repeat and double and go on doubling every half an hour, or 1 to 2 milligram per minute, maximum 300 milligram, then switch to oral. But then we don't follow this actually. We actually start antihypertensive labetalol IV plus oral together. So that way we are saved of when the antihypertensive effect of the IV drug is gone, the oral takes over. So that is why we get better response with labetalol, both IV as well as oral together. Nifedipine, all of us know, 5 to 10 milligram capsule, 6 hourly. Then hydralazine is 5 minutes, the short doses you have to take. You have to keep the patient in HDU, cannot move out as long as the hydralazine is running. So coming to the guidelines, I won't take much time. As I said, all the guidelines, all the recent guidelines, American Heart Association, International Society for Study of ISSHP, then Queensland Clinical Guidelines, ACOG, 2019, European Society of Cardiology, everybody, and NICE, of course, everybody has recommended treatment with the labetalol as the first-line therapy. In 2021, FIGO came out with this guideline, and they also said that non-severe hypertension, we recommend that elevated blood pressure in pregnancy be treated with antihypertensive therapy, and that the target systolic blood pressure and diastolic blood pressure should be 135/85. We recommend that oral labetalol, nifedipine, and methyl dopa, they have recommended everyone as a first-line antihypertensive agent for non-severe hypertension. Whosoever is used to whatever drug, you should start with that. There is no difference. In severe hypertension, we recommend that severe hypertension in pregnancy be treated urgently with antihypertensive therapy in a monitored setting. We recommend that severely elevated diastolic blood pressure be lowered to a target of 85 millimeter mercury, but gradually over hours to days. There is no high. We recommend also that oral nifedipine, oral labetalol, intravenous labetalol, and intravenous hydralazine be considered as first-line antihypertensive agents for severe hypertension also. So labetalol makes a place there also. And our own FOXY and also the Gestosis score, they recommended this. The dose was 200 to 1200 milligram, which is very true. You should start the labetalol tablet preparation in a chronic management, 200 milligram, that is 100 milligram twice daily, whatever may be the body weight of the patient. The starting dose should be 100 milligram twice daily. And then you gradually increase to 1 tablet thrice daily, 2 tablets thrice daily, or 3 tablets 4 times a day or something like that. Total 1200 milligram. Unless and until that 1200 milligram is reached, the change of antihypertensive or addition of a new antihypertensive, usually we add nifedipine retard, and then we add 10 milligram or 20 milligram BID twice daily. The preferred medication is when the baseline pulse is more than 100 per minute. That is one good point about just follow the pulse rate and give it, and the contraindication, of course, we have discussed. Now, there are some clinical evidences which I'll go in short, because oral labetalol has got many evidences and they have shown a lot of success, and there were a lot of women involved in these trials. But the 2019 Lancet study, it said that the primary outcome, BP control, was excellent, and the level of blood pressure, level of the drugs was excellent, and it doesn't cause much side effects. Coming to the end of my lecture, the immediate postpartum management is important. Apart from antihypertensive, we should take care of a few facts like monitor the patient in HDU until she begins to recover. If she's in hydralazine, do not move out of HDU until and unless the hydralazine is over or the maximal dose is covered. Continue magnesium sulfate for 24 hours after delivery. Of course, we are doing that. We have to remember also that the proteinuria often persists for longer time, but is of little significance. In fact, we have stopped doing urine for protein tests in the postpartum period in hypertensive patients. One word of caution about the non-steroidal anti-inflammatory drugs, which you often prescribe as analgesic, which should not be prescribed if we cannot control the blood pressure properly with antihypertensive. If you see swinging hypertension, it's better to withhold this NSAID. And of course, postpartum thromboprophylaxis is important. Which antihypertensive will you switch over to in the postpartum period? RCOG has recommended enalapril, it's an AC inhibitor. It's a good choice. However, monitoring of renal function and serum potassium is needed, and not many labs will have the facility of continuous monitoring of the serum electrolytes. Nifedipine or amlodipine can also be given. If blood pressure is not controlled, a combination of nifedipine or amlodipine and enalapril is a good choice. It's up to you. You can go step up. But I wonder how many days will you keep the patient? Except the cases of cesarean section, the vaginal delivery patient will go home, and therefore you need to have a close follow-up of this patient. It's very, very important. If still not controlled or tolerated by these drugs, you go for atenolol or labetalol. These are the recommendations in 2019. Some basic facts I'd like to just transmit to our audience. Do not attempt to normalize the blood pressure. We have discussed that, because rapidly lowering the blood pressure is associated with significant maternal and fetal effects. And these patients have a rightward shift of the renal, cerebral, coronary, and placental pressure or flow of autoregulation. And rapid decrease in blood pressure will cause a marked decrease in the blood flow in these organs. So both will suffer. No diuretics before delivery, but definitely give diuretics after delivery. So these are the few points that I would like to mention. And do not give diazepam anymore to stop an eclamptic seizure. I'm saying this, I know that we are not doing this, but I have seen many cases where the diazepam has been given when the magnesium sulfate failed to control the seizures. So few take-home messages. One is antihypertensives to start at around 140 upon 90 these days. We are not going for 150 by 100. In hypertensive crisis, oral nifedipine has been shown to be equally effective as IV labetalol or IV hydralazine. So provided the patient is conscious, you can have your reliance on the oral nifedipine as well. And as RCOG, FIVO, everybody has said that all the drugs are equally effective. Whatever drugs you are used to, please use that, but control the hypertension. Regional anesthesia and analgesia, of course, it is preferred, and there should be strict fluid control at the rate of 80 ml per hour. This is mandatory. And labetalol is the first choice recommended by almost all the guidelines, and is reasonably safe, orally active, and also useful in hypertensive crisis emergencies. Contraindication must be well taken care of, and liver function test must be evaluated. So that's all till now. I think I've tried to cover the most practical aspect. Thank you very much for your patient hearing.
Fantastic, Ashista. That was really very interesting, and you have covered it so well. And most importantly, you have given us certain very practical and important tips. Just one point I would like to clarify. If she is suppose quite well controlled with labetalol during the antenatal period, is it important to switch over to ACE inhibitors in the postpartum period, or can we continue with labetalol?
We can continue with that. The only problem is that the follow-up, that becomes a bit difficult, because now the RCOG says that if the blood pressure level is controlled and there should be monitored daily or regularly, then you should reduce the level of the antihypertensive. That becomes difficult once the patient goes home. So I think when you want to continue that kind of an advice to the patient that you use labetalol after the proper BP monitoring, who will do that? In a self-monitoring cases, it becomes difficult. And when the conditions are reversed, I think many
isn't
people
that monitoring required if you are changing to ACE inhibitors?
Yeah, that is, see, you are doing the renal function test, you are doing the hepatic function test in your own setup, but the patient may not follow your advice. So I think I don't know, I don't have much experience about using enalapril, but I have used in some cases with good benefit, good result. But I think that you can always use amlodipine, which is a quite safe drug, and many people are having amlodipine, particularly with a family history of hypertension, or the lady won't mind taking an amlodipine tablet in the morning. That is also possible. But nobody knows the switching of the hemodynamic changes, the return of the circulation to the vascular system, and that happens at which juncture no one knows. And that is why it becomes a bit tricky. So one antihypertensive which is easy to follow, easy to maintain, no investigation, or rather few investigations are necessary, that should be prescribed. And these are very important.
Yes, that's what we usually do, right? Like when we change over, we go on to amlodipine more than the ACE inhibitors. Any other comments from the chairperson? Do we have any questions?
That's the nice guidelines that has come up with the 2019. So I thought I will show you.
Right. Uh, is there any question from the audience? Are we getting any questions?
Bhavna will have to say, but there should be in the chat box. Bhavna,
Yeah.
is there questions? So I just wanted to comment, Ashishda, excellent talk as always. So I think now can we say that we can use amlodipine in more in the antenatal period as well instead of nifedipine? Can we safely say that?
Not really, because you see, amlodipine is a drug which is very convenient to use. But then not many studies have been done on amlodipine. At least nothing compared to the amount of studies that have gone for labetalol or even previously methyl dopa or even nifedipine. But then amlodipine has got the disadvantage that we do not have anybody's recommendation in the antenatal period with us. Numbers are very small. Very small groups of people have been studied with amlodipine, but we are not in a position to say that amlodipine you can start in the antenatal period.
As a matter of fact,
where it scores of a nifedipine it is a long acting. It is much more long acting than nifedipine. So I think there it scores of
nifedipine retardement.
I have a point to make in this context. As a matter of fact, amlodipine is being randomly used by many of us.
Yeah.
Okay? And I agree with Professor Mukherjee that unfortunately we do not have any strong evidence to recommend it in such a forum. But it's being used. But that's a very good question.
I have seen the numbers, Sukantha, 50, 75, 80, these are the numbers of women.
Exactly. We do not have any good quality, strong evidence to recommend this in this type of forum. That's what
also when the one antihypertensive is established in practice, you need to have a comparative.
That is the question. Why do we require it?
Otherwise, you
why do we require it? Unless the first choice drug is contraindicated or not available. If it is available, based on the strong evidence, we are going to use that.
We are lucky that even the physicians always refer a pregnant woman with hypertension to a gynecologist. So that is a good scope, because they also realize that in pregnancy, prescribing an antihypertensive is quite a risky affair. They think that way. Like we have the attitude towards insulin. So I think it's a good opportunity that, if we get good studies, good number of comparative studies, because today the labetalol is well established, nifedipine is well established. If you have to prescribe amlodipine, it has to score as good or at least as good as amlodipine or labetalol. Nifedipine and labetalol.
Thank you, Professor Mukherjee.
Thank you.
We learned a lot. I think we need to move on.
Yeah.
And
we never learned in PI in pre-eclampsia. It
learning.
Never ends.
So,
Thank you so much.
Please introduce Dr. Basha Mukherjee. Bhavna CV.
Dr. Basha Mukherjee. Even without any slide, I can introduce him. Dr. Basha. Yes, Dr. Basha Mukherjee. I think everyone in India knows him. Should I read it out?
No. Thank you, Professor Mishra. Thank you, Sukantha. It's a pleasure being here. And thank you,
Thank you,
Sneha.
Dr. Please, yes. We know that this is multisystemic pregnancy disease. We have screened it. We have tried to prevent it, but despite it had happened, we have controlled the blood pressure. But we need to terminate it.
Yeah,
for which patients, when, and how? Please do that. Please do that for us.
Thank you, Professor Mishra. Thank you. Pleasure to be here with AMOGs in a different capacity. I think Pratik had pulled me in a few of those AMOGs webinars before, and this is a pleasure being with Sneha. Dr. Sneha Bhuyar has been a brilliant worker in FOXC, in AMOGs, and the society which she led was Yavatmal, which has run away with many FOXC prizes over the last decade and a half. So Yavatmal Society, which Sneha once led and was a president,
is a very famous society of Foxy, where they have won many prizes of Foxy in the last decade and more. So Dr. Sneha has been a wonderful worker. First of all, I wish her all the very best for the upcoming elections, and I'm sure that all the voters will remember the great work that she has done, not as a chair of breast committee only, but before that and also in other capacities. So thank you, Sneha, for being organizing this. Thank you, Bengal Obsgyne Society. We have two new fresh office bearers who really jumped on this program, and Bengal Society is now a part of it officially. And thank you, wonderful talks by Dr. Sita, Dr. Ashish, and I'll try to save some time, which and make it very short, the one which I have been given. So I'll just share my screen. Yeah, can you see the slides?
Yes.
Okay.
Yes, yes.
Some colors out there.
Yes, some beautiful flowers.
So delivery decisions in hypertensive disorders of pregnancy. A very short and sweet topic, because delivery decisions is the topic, and I will not go 1 inch here and 1 inch there. Ashida has really given a very nice overview of the entire thing of HDP. I don't think you could have said more. He said much more than antihypertensives, but again, it's so important for the entire perspective. But delivery decisions, as Professor Shukanta Mishra rightly says, you've led her till the almost end, but unless the end is all right, nothing really counts. So unless you get a healthy mother and a healthy baby at the end of all this, your antihypertensives, your screening for HDP, nothing really counts. So you have to do the end well, and that is important, and that's where delivery decisions come. And the question which everybody asks is, to do or not to do, that is the question. So this is a face of a very complex and perplexing obstetrician. In the end, when hypertensive disorders of pregnancy has really puzzled him and or her for a long time throughout the pregnancy, and now when to end it, when to pull the plug, and when to say enough is enough. So to do or not to do is the question, and that's what we will be answering. And for delivery decisions, I think what we would refer or would look at is the mode of delivery, the place of delivery, the timing of delivery, the maternal indications for delivery, the fetal indications for delivery, and some clinicians' distress, where clinicians' distress needs that delivery needs to be done. So these are some of the issues which we will highlight over the next 10 to 12 minutes. I promise not to go beyond that, because this is a topic which does not warrant more discussion than this. But I'm sure if you have points which we can all discuss together, that would be fine. So mode of delivery, whether is it a vaginal delivery, is it a section, or is it a assisted vaginal delivery or instrumental delivery, would depend partly on the urgency to deliver. So if it's an eclampsia where you really have to deliver her in the next few hours, you will be doing a pelvic examination, seeing the favorability of the cervix, and assessing whether you have time to do a cervical, to ripen the cervix, which often you would not, and then you would be going for a straight section. Gestational age, to some idea how early it is. If it's very, very early, we are a little hesitant to go ahead with a section, depending on what the viability of the baby is, what the estimated weight is, what the chances are. So at a 26, 27 week situation, would you do a section? I think that's a discussion which we will have with the parents, with the neonatologists, and come together to an option about what needs to be done, what can be done, and what would be the outcome if such a thing would be done. Favorability of the cervix, I've already said, if you have time in hand, if it's a severe PIH where the end diastolic volume is just coming down and you still have that very 1 day in hand, then you give those steroids, you give your Magsulf for neuroprotection, and then you do some cervical priming, and then try to do some, if a normal delivery is what you're looking at. Severity of the FGR, the more severe the FGR, the normal thinking or the logical thought was that the baby, don't torture the baby enough, or the baby may be too fragile to go through the birth canal and come out through all the turns and twists of a normal delivery and labor. And so that's something which some people think if it's whether that would be a good proposition if a baby is, if it's very severe FGR. Obstetric indications for section, previous to Caesars, breech, other things would definitely be going for section. That would not be coming here. And assisted vaginal delivery to cut short the second stage if she has opted for a vaginal delivery, or you are trying a vaginal delivery in her where the hypertensive disorder is not that severe, it's mild, and you have allowed her to go into a normal delivery, then you would possibly most likely not like to prolong the second stage and then try to shorten it. Coming to the place of delivery, where would you like to deliver a hypertensive disorder in pregnancy mother? A very short and sweet answer is it has to, preferably has to be in a tertiary center. If you're doing it in anything less than that, you really are taking a chance, because you never know when a less severe hypertension will become a more severe hypertension, and when you may have to deal with something much more complicated than what you start with when the woman is entering labor. So if a woman has a mild hypertension, of course you think that you can manage her in a secondary center, and possibly you may not think of a tertiary center initially, but again you must be ready that at some point of time, if things become complicated, then you may need to shift. So a mother, ideally there should be an HDU facility, because if the HDP is severe, if she has issues where she have organ dysfunction, then definitely there is a chance that she may need special care after the delivery, especially if it's something towards pulmonary edema, neurological problems, definitely hepatic disorders, renal problems, and definitely there is a chance that this lady has to be managed in a setup better than just a general ward. And for the baby, depending on how much the FGR is, whether an NICU would be required, possibly in many cases it would be required to start with, in some cases possibly straight to the nursery. If that FGR is not so much, it's 2 kg, 2.2 kg, then a lot of pediatricians will say, let's see for a couple of hours, some hours in the nursery. If the baby is fine, if they're feeding well, then possibly we won't be doing more there. Blood transfusion facilities, that's something which, if it's there, then that would be very much welcome. Again, it's there in most of the tertiary centers. In utero transfer is always preferable, we say, but I think one important point which comes up again when we talk about this is stabilize before shifting. And this stabilization would possibly include giving antihypertensives, giving magnesium sulfate in a case of impending eclampsia or already eclamptic person's got a fit, and then that would be the situation. Dr. Ashish Mukhopadhyay has already spoken about full PRs or PREP-S. Of course, we haven't gone into the details of the charts, but those are some validated risk predictive models which the NICE says can help us in determining which is the place of delivery. But as you understand that HDP, most people who've done reasonable amount of obstetrics know that things can suddenly go wrong, and so you need to really be prepared for all type of situations. Timing of the delivery, when should delivery take place? So if you pulled her till 34 weeks, a lot of us feel very happy. 34 seems like the peak of the mountain, that once you cross that, oh, then now come on, let's go and deliver her. So the minimum, if it's less than 34, antenatal corticosteroids, magnesium sulfate for neuroprotection would be preferred. 34 to 37, they said still antenatal corticosteroids, not much role of magnesium sulfate there. And 7 weeks, if it's the SOGC says unless there's a strong indication for birth, it doesn't make sense to deliver less than 37 weeks. And NICE says unless the blood pressure is 160 by 110, you don't usually think about delivering at 37 weeks. You can push until term. And Gestrosis says if it's a gestational hypertension, then you can go till term, and as long as the blood pressure is under reasonable control. Of course, anytime there are complications, there are seizures, there's some other problem, fetal distress, which we'll be discussing soon, then of course the timing of delivery can happen anytime. But generally we're talking about cases where you have understood the hypertension, possibly late in pregnancy, 20, 24 weeks, some cases chronic hypertension where she was on hypertensives before pregnancy, and how you brought her throughout the antenatal period and what's happening in the end. If it's under reasonable control, maybe not exactly full-blown help, but just the enzymes just a little bit up, but not so much. The platelets are okay. The other features are okay, then possibly you can push her till some amount of time. Involve a senior obstetrician. The decision making says nice, which may be a good point for timing of delivery, because sometimes you don't want to have the full thing on yourself, especially if you work in an institution where you have other people there. Then of course it may be a good idea to get a senior obstetrician in the picture. So what are the maternal indications for delivery? So delivery decisions, when would, for the mother's sake, you will have to do a delivery. So we understand that obviously there are, this is from the MBBS time and MSMD time, whenever you talk about anything, you have to say maternal causes and fetal causes. So maternal indications for delivery in a case of hypertensive disorders in pregnancy. Uncontrolled hypertension despite treatment. And now this is easy to say, but NICE has gone on to define what is that means. So it says that 3 or more classes of antihypertensive in appropriate dose given, and even after that you can't control hypertension, then you will say call it uncontrolled hypertension despite treatment. It's not just labetalol or labetalol, 200 3 times daily, 300 4 times daily, up to your 1800 milligrams. Not just that, you need to add a few more classes of antihypertensive and try to see whether your pressure is getting under control. Severe HDP early in gestation. So how early, how much, again, this is again subject to a lot of discussion, but if it's 21 weeks, 22 weeks, 24 weeks, then you really have to take a call very early whether you want to pull the plug or carry on. And that discussion, again, it's not just a guideline which will follow. There'll be discussion with the patient, with the relatives, with the ICU people, with other people involved. Progressive deterioration in hepatic, renal, or hematological parameters can push for a delivery, and that we understand most of this entire pathophysiology is related to the pregnant state. So once the pregnancy goes, most of this will correct with time. But of course, you need to monitor and you need to find out. But this is one of the indications where she would need to be delivered. If there's evidence of abruption at any point of time, of course, you would not wait to watch the abruption increase. You would like to deliver her fast, check her coagulation parameters, check her renal parameters, which are the two main concerns for abruption, and of course the fetal well-being before you go ahead. Features of eclampsia or impending features. So this is one interesting criteria. Like here you are giving magnesium sulfate, of course, and if you're giving magnesium sulfate according to your collaborative eclampsia trial or your MAGPIE trial, then obviously you would like to deliver also at the same time. Though we have had instances of magnesium sulfate given, things settling and the pregnancy going on for some more time, but more or less in all practical situations, once you give you magnesium sulfate and the dose of magnesium sulfate, you actually are committing yourself to delivery in most of the cases. Signs, symptoms of pulmonary edema. Of course, as Dr. Ashish Mukhopadhyay also has, I think, mentioned in his talk, that this is some kind of thing when you really have to say enough is enough, and for the mother's sake, delivery is required. What are the fetal indications for delivery? Severe FGR, less than 5th percentile. Again, this a lot of people may say that severe FGR is variably defined, and you just won't go with severe FGR alone unless it's associated with Doppler abnormalities. So now we refer to Dr. Sita Ramamurthy Pal, where the fetal medicine of colleagues will come into the picture to say how much would be how much of, they'll look into the ductus venosus, they'll see the middle cerebral artery, but most of us would be happy with the umbilical artery or absent or a reversed end diastolic flow. We'll say enough is enough, and we'll say that we'll have to deliver her in the next 24 hours. Fetal demise, of course, and if there's an NST being done in these cases and suddenly you see a flat line or you see a prolonged deceleration in a woman who's not even gone into labor or contracting, in those cases you'll see something is of course very much amiss and you would like to deliver her at the earliest. Coming to the clinician's distress, this is my last slide of this discussion. So if none of these things are there, then why the clinician distress and dilemmas which may come in? First is pass on the buck to the pediatrician. I've done enough. I've just pulled her from 27 to 32. I had 5 weeks of distress, and now it's time that the pediatrician takes care of the baby and let his or her distress start there. Get past your sleepless nights. No more sitting on a volcano. Enough of the time you're sitting. Anytime she could throw a fit, anytime the baby could go for an IUFD, you're really worried. So I think now it's all done. I think enough is enough. Now let's move on. I think let's pull on the plug. Let's have a delivery. Fear of medical legal issues in any adverse outcome. Though you have explained to her, though you have counseled her, though you have signed with the relatives, though you do video recording of your discussion, whatever you do, you understand that medical legal issues loom large in any complicated case of obstetrics, and an adverse outcome is definitely what will put you at a back stage, and everybody will often be pouncing on you regardless of what's happening. Better to be safe than sorry, so you overtreat. That's what the thing is in private practice. You often overtreat, give more medicines, do more tests, and try to do delivery even earlier than what's in the guidelines of the things. Patient relatives do not understand guidelines. So it's no longer talking to them and saying that this says this, NICE says this, SOG says this, I have done this in this way and this and that way. You can put your arguments to a courtroom, but you can't put it to a baby who's to a mother who's lost a baby, or a family who's lost a mother. So I think those are things which we can console ourselves, but in the real life, it sometimes is a little difficult and distress. So that's all for delivery decisions in hypertensive disorders of pregnancy. So to do or not to do remains the question. And I think that is something which all of us in our different stages of managing obstetrics will keep on trying to delve into this and try to find the answers. Thank you very much. Thank you.
Thank you, Dr. Mukherjee. As always, your short, sweet, and beautiful talk, highlighting the important clinical points, extremely useful for all the clinicians. But the decisions will always be questioned. That you know very well. We all know, in fact. And in tough time, yes, Dr. Sita is always there to help us with her clinical expertise. So when to do or when not to do. Thank you very much. Are there any questions from anybody else or any input from the chairpersons? Because there are a lot of things that can be discussed, but that I think we have passed time also.
Yeah, we'll have the discussion, the panel. I think the panel, interesting panel.
Panel is there. So, Dr. Moshumi, Dr. Joyita.
I loved your last slide, Varsho, but sometimes even passing the bucks to the pediatricians do not help nowadays. Sometimes down the line, you will be questions, why did you do it? Because there were lots of complications later on in the child. So it's really, really a very tough decision to take at times.
To be or not to be?
To do or not to do? Do or not to do?
No, but to be or not to be an obstetrician?
To be or not to be an obstetrician, or to be or not to be a... Yeah, that's it. To do or not to do is the thing.
Okay.
Chalo,
okay. Thank you very much.
All the best, Dr. Sneha, and I'll follow up.
Thank you, Dr. Sneha, for including us.
Thank you so much for having me here with you all. Thank you. Thank you so much for that.
Love to be here. And convey my regards to Dr. Rajendra also.
Yeah, thank you so much. So, yes, Dr. Sita, should we move on to the panel discussion?
Yes, ma. Yes, we can move on.
I think, Sita, do you want to introduce the panelists?
Yeah, I'll do that.
Yeah.
Can you just show the slides, please?
Yeah.
So we have a very interesting panel on case discussions. A lot has been discussed on theory now, and now we will see how we can practically use all this in our day-to-day practice. So the first one is Dr. Alpana Chetri. She's a very active member of our BOGS. She's a joint clinical secretary in the past year, and she's an associate professor of the CSS College of Obstetrics and Gynecology, Child Health, Kolkata, member of the Medical Disorders in Pregnancy, FOXI. Next, we have Dr. Ram Prasad De, who's been the past president of, is the current vice president of the BOGS, and he's been the past secretary. He's editor-in-chief of the Indian Journal of Perinatology and Reproductive Biology, national corresponding editor Jogi, and a winner of multiple awards and multiple publications to his credit. Thank you, Dr. Ram. Next, we have Dr. Bidisha Roy Chaudhary, a young brigade and a dynamic obstetrician, fellow of the Minimal Access Surgery, consultant obstetrician and gynecologist at IPGMR and SSKM Hospital. Welcome, Bidisha. Next, Dr. Mariam Khanam. She's a consultant gynecologist at the ESI Hospital, Shialda, managing committee member, very active, sincere worker of our society, and has been the assistant secretary of scientific committee of our AICOG 2023. Welcome, Mariam. And then we have Dr. Sanjeev Dotto, consultant obstetrician and gynecologist. He's an associate professor at the Sagar Dotto Medical College and Hospital, managing committee member, and he's been the PPH convener of the AICG Kolkata, secretary of the Adolescents Health Committee, and has presented multiple papers in national and published in national and international journals. Welcome, Dr. Sanjeev, and over to you, Dr. Sneha. Thank you.
Yes, thank you so much, Dr. Sita, for including all the wonderful panelists, and I'm thankful to all the entire Society of Bengal Obs-Gynae Society. And without much ado, I think we'll move quickly on to the panel discussion. Once again, I welcome all my panelists, Dr. Alpana Chetri, Dr. Ram Prasad Dey sir, Dr. Bidisha Roy Chaudhary, Dr. Mariam Khanam, and Dr. Sanjeev Datta. I hope you all can see my slides.
Yes, ma'am. Yes,
Yes.
ma'am.
Yes, ma'am.
Yes, ma'am. Yes.
So, friends,
Go to the slideshow. Yes.
I think I have done that.
Yes. Okay.
Okay. So, friends,
Yes,
all of you know, hypertension, hemorrhage, and sepsis, these are the three major direct causes of maternal mortality. And as Dr. Sita has discussed with you, the prediction and prevention, and of course, the preparedness to face the key. Dr. Ashish has discussed with us what are the preventive measures, and also the antihypertensives, when to start, which antihypertensives to be chosen for the management. Of course, the most important part, Dr. Sita has discussed the careful history taking, the maternal characteristics, the HDP-Justice score, and of course, you have certain biophysical and biochemical tests that can predict HDP. To prevent the low-dose aspirin and high-dose calcium and vitamin D, in spite of all this, we have not significantly reduced the incidence of HDP and the complications and morbidity and mortality associated with it. When we are talking about this maternal mortality, friends, these are not just the numbers and rates and ratios. These are women, they have their faces, which we obstetricians witness in the faces of their distress and despair. And these are the faces which keep haunting our dreams. I'm sure those who have faced the, such severe hypertension, eclampsia, or maybe a near miss case will not forget the face of that woman. So women who are dying not because of the disease we cannot treat, but because the societies have yet to make the decision that their lives are worth saving. That is how it is expressed by the past figure. Save our women's lives. And with this, quickly we start and go through a case discussion here. Dr. Alpana, this is a patient who is a young primary gravida belonging to a low socioeconomic status, and she has no medical illness known so far, and no significant family history as well. Till now, she is a booked case and uneventfully coming up to this stage. Suddenly at 32 weeks, when she comes to you for a routine checkup, you find that her blood pressure is 140/90. Should we label her as hypertensive? And if not, then how and when should we label her as hypertensive?
Since this patient has come at 32 weeks of gestation with no prior history of increased blood pressure, so once we see her for the first time, you see in the OPD, at least it's ideally you have to measure in both the arms, as Dr. Ashish Mukhopadhyay has said, and you tell her to take a rest, as there's a white coat hypertension. There may be a chance of white coat hypertension, and you just measure it after 2 hours or so, or minimum of 2 hours or more. Yeah, more than 4 hours. You just recheck it, and if it is persistent, then you can think it might be a case of she is having hypertensive. She might have hypertensive disorders in pregnancy.
Yes. So, sometimes you may just find the patient has come traveling from a long distance and she's not comfortable. Immediately she rushes to you and you take her blood pressure. It may be just high. So you have to make sure that she's physically and mentally relaxed. Her bladder is empty. The clothing are comfortable. The room is comfortable. And, even the cuff size is appropriate. That is how we have to go for the blood pressure measurement. So if you find a single reading which is high, maybe you give us some time and you again re-measure the blood pressure. If it is still so very high, 140/90, if it is still high, then of course we have to give her a time of 4 hours where you have to measure it again. And if that is high, then you have to label her as hypertensive. Meanwhile, of course, we have to send her, we have to inquire for other things. So whether she belongs to a category of severe or a non-severe hypertensive, according to you. How do you know whether she's a case of severe hypertension or a non-severe hypertension?
So since her BP is 140/90, you can either admit her for a day care observation, and then you can send her for investigations. You do put proteinuria, and at the same time send blood for LFTs, RFTs, CBCs, and once the investigation comes, if you don't find any alarming results, you can just let her go home and just tell her to do twice weekly monitoring of blood pressure and follow up with you. Yes.
Yes. So the message very well delivered. Only few additions to this, that you have to, advise, you have to talk to the patient whether this blood pressure, just don't go by the blood pressure. It can be severe as well, sometimes even with 140/90. So blood pressure is not always a dependable indicator of severity. You have to inquire about whether she has any alarming symptoms like severe headaches, visual disturbances, maybe upper abdominal pain, and maybe oliguria. Whether she has any alarming signs like, hyperreflexia, if her reflexes are brisk, and or she has got epigastric tenderness. So all these signs also simultaneously, as you have very well discussed, that you have to send her investigations, which includes right from complete blood count. And so what all investigations you want to do for this patient to categorize her as severe or non-severe?
We have to check her CBC to see every evidence of thrombocytopenia, and also the urea creatinine, and you just go for LFT liver enzyme tests, and if possible, you could also do a color ultrasound and a color Doppler if you need. And if you says of any alarming symptoms like blurring of vision, and you can go for a fundoscopy examination.
Correct. So whether you would like to admit this patient, and would you begin, Dr. Mariam Khanam, I'm asking you this, I want to know from you whether you would start antihypertensives at this point of time, which drug you would prefer, and how would you go ahead?
Yes, I will like to start antihypertensive at this level. I will start with the oral labetalol tablet, 10 milligram twice a daily, and ask her to if it is possible, then we'll ask her to self-monitor the blood pressure in home. And if it is not controlled, then I will gradually increase the dose.
Yeah, just want to know what is the evidence to start the antihypertensives at 140/90.
Ma'am,
the NICE guidelines say that you have.
As per the guideline, it was 150/100, but just now I have came to know from the Dr. Ashish Mukherjee's talk that recently it is 140/90. That's why I'm saying this.
Yes, perfect. So Dr. Sanjeev Datta, when to start antihypertensives? That is what we have heard from Dr. Mariam. Whether you have some recent guidelines, and how do you decide which antihypertensives? We'll quickly go over the discussion.
Yes, ma'am. Can you hear me, ma'am?
Yes, yes.
Yes,
Sure.
okay. So right now the guideline says completely in favor of labetalol. In fact, all the guidelines are, it's not that in our student days we used to know that, we used to read that all the three drugs like levetolol, nifedipine, and alpha methyl dopa, all are first line drugs. It's not that in nowadays. So the levetolol is the drug of choice unless she has a specific problems that may arise out of levetolol. That means we need to rule out few things like whether the patient is having bradycardia, patient is having history of asthma, and patient is having any major cardiovascular disease, etc. So after excluding that part, most of the time we can give levetolol, and that is the first line of drug according to the NICE guideline and the other guidelines as well.
Yes. So, as I have already discussed with you, that NICE guidelines used to say that 150 by 100, that is a cutoff to start the antihypertensive. But World Justice Organization, FOXI, and ICOG, all of them recommend 140 per 90 millimeter of mercury. The blood pressure warrants the use of antihypertensive drugs. And of course, you have at this point of time, you have three options: labetalol, alpha methyl dopa, and oral nifedipine tablet. It's a retard tablet. So how do you choose between the nifedipine and labetalol?
Madam, first I will go through the patient's records to know whether she has any predisposing factors for any specific diseases or not. So if I find that she doesn't have any contraindication for levetolol, then I would start with levetolol because it is a first line drug.
What contraindications you want to see for her?
Yes, ma'am. I said if she's having bradycardia, if she's having asthma, if she's having any cardiovascular disorders, major cardiovascular disorders, then I would prefer to go with nifedipine. Otherwise, I would stay with levetolol only, and to start with, I would start with minimum doses 100 milligram BD twice daily.
So, Dr. Alpana, what are the advantages of labetalol? That is what I would ask from you.
Actually, labetalol is very safe. It doesn't decrease the pressure suddenly, so it might not lead to complications like abruptio and sudden fetal demise. Yes, and it doesn't. It crosses to some limit to the placenta, but not much. It doesn't cross the placenta, and it is it has yes,
definitely, you're right that it decreases the blood pressure optimally, and it maintains it stabilizes the patient. Also, it doesn't interfere with the uteroplacental blood flow, and that is why there's not much of risk for fetal growth restriction. At the same time, when your patient is on oral labetalol, sometimes if the patient goes into hypertensive crisis or sudden severe hypertension, you have the option of injectable labetalol at your hands. All of you know that it's a selective alpha-1 receptor blockade, and also it works by non-selective beta receptor blockade. But then if you talk about, I have heard many patients, many obstetricians saying that, repenting about alpha-methyl dopa. So Ram Prasad sir, I would like to hear from you, because you are an experienced obstetrician who must have used this alpha-methyl dopa. I'm sure. Yes.
Yes. Thank you. Why you are not in favor of? Am I audible?
Yes.
Hello.
Yes, sir. Yes, sir.
Why you are currently not in favor of alpha methyl dopa? We have a experience of using alpha methyl dopa more than 2 decades. But at that time, the drug of labetalol was not readily available, and also some of the nifedipine though available, the route was not straightforward at that time. The sublingual route of that, which is not indicated. The problem is alpha methyl dopa. Is number one problem is there is only the drug is orally available. Number one, there is no drug intravenous available as long as the labetalol. Second thing is it is not also widely available in the market also. The dose is also slow. What is the acute control? It does not help in acute control, and moreover, it is also not going to be used in postpartum. Once you have used this alpha-methyl dopa, you must have to stop the drug postpartumly after 48 hours. These are all things that we are currently not in favor of alpha-methyl dopa. And moreover, if that drug has some sort of a psychological disturbance in the postpartum patient also, so that is why you are not nowadays.
Yes. So the first and foremost,
told that it takes longer time. Yes.
Yeah. You're right.
24 hours and the yes. the death have been in the 3 times a day, there is non-necessary fetal heart rate, and hematological problem is also there, headache. And point I also already said, it have to stop the drug after in the postpartum period.
Yes.
Please.
Perfect. You have discussed it very well because I'm sure you have used it in day-to-day practice. The first and foremost, it is not available nowadays. That is the most important reason. But there are few people who repent that, they say that it was a very good drug. But the problems with this drug, as you have very well discussed, that it was the onset of action was very late, that is almost 24 hours. And of course, there was a risk of orthostatic or postural hypotension, and as you very rightly said, the sedation, postpartum sedation, which was to interfere with the breastfeeding as well, and the psychological problems, confusion, sometimes headaches also. You used to get confused whether it is because of the whether this is an alarming symptoms or it is because of the drug alpha-methyldopa, and the hematological problems like thrombocytopenia or even the false positive Coombs test, in few of the patients. That is how it was. So Dr. Bidisha Roy Chaudhary,
Yes, ma'am.
as a part of your management, in addition to all this stuff, what is your opinion about the bed rest and salt restriction? How do you advise your patient?
Yes, ma'am. Salt restriction has a definite role. Like we advise patient to not to take extra salt. And but regarding bed rest, previously in the previous days, patient were advised bed rest. But nowadays the recommendations is like if they are advised bed rest, there are increased risk of thromboembolism in these patients. So it doesn't have any role in better, like in controlling the blood pressure also. So it is.
How do you tell your patient to restrict the salt? How do you advise practically?
I usually tell them not to take any extra salt in the diet. Whatever salt is used in the cooking, they can take that.
Yes.
Because that is the thing.
So in fact, this is not a salt restriction. We allow them to take appropriate quantity of salt, only not to take the extra salt. So bed rest, in fact, it doesn't have any advantage. Complete or strict bed rest can be hazardous because of this prolonged, recumbency. They may, also suffer from thromboembolic episodes. So that is how, yes, you have to take care of all these factors. So friends, challenges are what makes life interesting, and overcoming them makes it meaningful. That is how it is expressed. And, this obstetrician who is managing the case, she was from the older thinking, she thought it's a mild hypertension, and she just made the patient go home, saying that if at all you have alarming symptoms, you can report to me after maybe, and then you can follow up after 1 week. So friends, 5 days later, this patient was brought to the hospital by the relatives with severe headache, nausea, upper abdominal pain, and her blood pressure was 170 by 110. Reflexes were brisk and epigastric tenderness was present. Now, what is your diagnosis for her, and how would you go ahead with the management?
Now
yes, Dr. Mariam, this is a question for you.
Now patient, she has presented with BP 170 by 110, and there is other premonitory symptoms also, like epigastric tenderness, and BP is also raised. So it is a emergency now. It is a hypertensive crisis. She presents with acute emergency, and first of all, I will counsel the patient. The patient party counseling is also important, and after that, first I have to stabilize the patient.
Hospitalize the patient first.
First admission, counseling, and I will call for help, and I will prepare for giving Maxelf administration. Simultaneously, I will do a IV access, send blood for the routine blood testing, including liver function test, renal function test. I will catheterize the patient to monitor the urine output, and I have to lower the blood pressure. I will give
because she's got premonitory symptoms. You're giving her Maxel, but she's got very high blood pressure. And what are you worried about? Why you are worried? 170, 110. What complications she would land up into?
She can, anytime the volcano can erupt, she can present with fit.
So anybody wants to add anything on this? What antihypertensives you want to
IV injection labetalol.
Yes, yes.
First 20 milligram IV, then I will check the blood pressure after 30 minutes. And if it is not controlled, then I can increase the dose up to the total doses.
Okay.
220.
Okay. So Dr. Sanjeev, 170, 110, whether this is a hypertensive emergency or whether this is a hypertensive urgency, how do you decide that? And whether your management will change as per this diagnosis.
Ma'am, the management will not depend upon hypertensive emergency or urgency. I will, in
Correct.
either case, I will give, I will try to stabilize the patient in all forms.
Yes.
Like I will try to reduce the blood pressure as much as possible to make it in a non-severe range. So for that, I will give, maybe I will give IV levetolol, or I can also give injectable hydralazine as well, although there are few side effects that can happen. Or I can even start with tablet. Dr. Ashish Mukhopadhyay sir already said that oral nifedipine or oral levetolol can also be given in hypertensive emergencies. But obviously that too, the trial should not go for long. We need to check whether the blood pressure is adequately reduced in very short time. And after the blood pressure is reduced to less than 160/110, then we can go with our decision whether to, if we have already given magnesium sulfate to this patient, and if she is preterm less than 37 weeks, then we can give at least one shot of steroid as well. Although there is a good chance of hypertension out of steroid, but that needs to be monitored as well. And magnesium sulfate will also take care of neuroprotection if it is less than 34 weeks. And after that, the things will depend upon how we are smart enough to reduce the blood pressure, and if we can go with if the blood pressure is well reduced, and if she is far away from term, then we can continue with the pregnancy little bit more, and we can go up to but she is a case of severe preeclampsia. We cannot continue the pregnancy right now. So if it is more than 34 weeks, then we will have to plan
go
for
to that
delivery.
later on. Suppose this patient of yours who's got a severe hypertension, you have started her on IV labetalol. How, suppose you have started with 20 milligram, 40 milligram, how much maximum you can give? And if at all she's not controlled on this, then what is your second line of drug?
Yes, ma'am. We can definitely start with 20 milligram IV. We can give some stat doses, and we can continue with infusion pump. That too, in infusion we can go with 1 milligram per minute.
Yes.
Or if we want to give in bolus, then we can start with 10 to 20 milligram, and we can add up depending on how much blood pressure is getting reduced. And then we can go up to 200 milligram or maybe 250 milligram. Here it is 300 milligram. Okay. Yes,
over
yes,
24
that
hours.
we can
Correct.
go.
Correct.
Yes.
So suppose
Hello.
yes, Dr. Ramprasad sir, you can add to this.
I'm trying to say that
I think we are not able to hear you. I think.
Can you hear me?
No, your voice is cracking, I think. Can all of you hear him?
No, there's cracking of the voice. Yes.
No, ma'am, the voice is cracking.
Yeah. So, sir,
From the try again now.
You can close your video and you can talk. I think it will work.
Yes. Hello.
Hello. Yes, sir.
Hello. Hello. Can you hear me?
Yes.
Yes,
Definitely.
yes.
Please go ahead.
What I am trying to say, the starting of intravenous labetalol with the 20 and 80 milligram is escalating, that is being controlled. What, though not straightforwardly written in the guidelines, what our clinical experience, what we prefer in our medical college is to take oral drug. This is our preferable choice.
Yes.
Start with the oral labetalol. Otherwise, the half line of this drug is basically drug.
I think your voice is cracking, sir. We are not able to hear you.
Oral labetalol.
Yeah. So what the standard guidelines say that, and what our for effective reduction in the blood pressure for severe hypertension, definitely we have two main options. That is, one is IV labetalol and second is oral nifedipine capsule, the orange color capsule, which is we have 10 mg, 5 mg and 10 mg. So we have been using even the oral nifedipine capsule 10 milligram because the onset of action is within 5 to 10 minutes. The peak action is within half an hour and the duration of action is 6 hours. So it effectively controls the blood pressure. But yes, given a choice, I'm sure all of us are well versed with using IV labetalol nowadays, starting with 20 milligram. Wait for 10 minutes, see that you get the desired reduction in blood pressure. If not, you double the dose, 40 milligram. If not, still you can increase to 80 milligram and still you can repeat 80 milligram with a maximum of 300 milligram. Dr. Sanjeev has very rightly discussed. So if the patient doesn't have all these contraindications, I think IV labetalol is a safe and effective drug. Of course, if you are well versed with using oral nifedipine, that is also a very promising and effective oral medication. Hydralazine is one drug which is very, very effective if it is available. You can start with 5 milligram intravenously and repeat every 30 minutes. You can repeat 5 to 10 milligram, and with a maximum of 20 milligram intravenously you can do. Of course, it may increase the risk of maternal hypotension. You need a very stringent monitoring with this drug. Of course, you have sodium nitroprusside and NTG infusion also. We have managed few cases of malignant hypertension where you have to give the NTG infusion also. So that goes in the domain of physician, and for that definitely you need a HDU or ICU. That is what. Yes, definitely.
Ma'am, one point, hydralazine is also available in capsule form 25 milligram, but I don't know, it's not there in the recommendation. Maybe only the IV dose is recommended.
Yes,
not
because
the
it's a
capsular
severe
form.
hypertension and we got the immediate effect. That is why the intravenous hydralazine is discussed here. So what should be the policy of lowering the blood pressure? Anybody can take up this question. I think Dr. Bidisha, you can take up this question. How much should you lower the blood pressure? See, 170, 110, you have the, fear of getting intracranial complications, convulsions, abruptio-placentae, pulmonary edema, hepatic rupture, even so on and so forth. So how much should be the blood pressure reduced at the first instance? How it should be maintained? What is the optimum level?
Yeah, it should be reduced up. We can reduce up to 135 by 85. That is the latest recommendation. And if the patient is maintaining around that, then it's fine.
Is it recommended to reduce to such an extent, 170
That
by
is the no, ma'am. The means the lowest level that can be achieved is that, but not beyond that. And if it's reduced around
anybody
155,
actually 135 by 85 is the you have to maintain while treating a hypertensive patient. You have to maintain that level of pressure. Do not lower it excessively, at least to 135
so it
by
has to be
85.
reduced
That's
slowly,
what you have to maintain it. Yes.
Yes. It has to be reduced slowly over a period of time. The initial reduction in blood pressure is said to be, only 15 to 25% of the mean arterial pressure. That we take it as 170, 110. You take it as 160 by 100. Then you lower it down slowly. So it should be a gradual lowering of blood pressure, and it shouldn't be a sudden one. All of you know this, protocol very well. The labetalol, nifedipine, hydralazine we have discussed. Only warning about this capsule nifedipine. I'm sure 35 years back, those who have worked in medical colleges also and private hospitals, we have used this drug very extensively, and we have witnessed the mishaps which have happened because of the sublingual nifedipine. So it's a strict warning that never use a nifedipine capsule sublingually, because it may lead to sudden collapse and you may even lose your patient. So that is what the message here. Any other drugs all of you can just share with us, and then we can go ahead. Any other drugs you have? Or I'll just summarize this. Nicardipine. Nicardipine is also a very, it's one of the promising drugs which the physicians are using, the cardiologists are using. It's a second generation dihydropyridine derivative, and it's almost 100 times more soluble than the nifedipine. It can be administered intravenously. The onset of action of intravenous nicardipine is between 5 and 15 minutes, and the duration is also 4 to 6 hours. So it is very, very effective and convenient as well. One more is a small ultra short acting cardioselective beta adrenergic blocking agent, and because of its pharmacokinetic properties, some of the authors consider this as an ideal beta adrenergic blocker use, because as an obstetrician we are not well versed with this drug, and also the safety in the neonate is not established, and that is a very reason esmolol we are not yet using in our day-to-day practice. Now we have stabilized this patient. We have got the optimum control of blood pressure, and she is 32 weeks. So how long you can pull on this pregnancy? What other things or findings and investigations would warrant the termination prior to 34 weeks? Dr. Alpana.
If she has, if her symptoms does not decrease with the use of all these medications, even her clinically she is deteriorating. If she develops eclampsia, or in cases of pulmonary edema, and other investigation parameters like LFT gets deranged, RFT gets deranged, there is thrombocytopenia, and on Doppler you have to, if you see a reduced end diastolic flow or absent end diastolic flow, that warrants that needs
yes,
to a termination before 34 weeks of pregnancy.
Yes.
And yes.
So what is now all of us have discussed the role of antenatal corticosteroids, but what is the role of magnesium sulfate, and how much and how frequently do you use this? Which regime do you prefer? I would like to hear from you, Ram Prasad sir.
Yes. Am I audible?
Yes, sir. Yes.
Yes. That must be considered Still now, this is the recommendation. Only thing is that regime everybody knows the pitch both before the
are you all able to hear, sir?
You off your video. You only talk with the audio system.
Yeah. Please.
So, hello, am I audible?
Better.
Video is off. So in the medical college we are using the picture regimen is we are using this one is also equally effective.
Hello.
Hello.
Yes. Please go ahead.
Yes.
I think
so the regime we are using, and this one is also equally effective. There is no problem. Yes.
Okay. So here for this case, we are using this prophylactic magnesium sulfate. Sir, my question was whether you are using this as, because what is the difference between the dosage and the regimen of prophylactic and therapeutic magnesium sulfate? Is there any difference? Dr. Sanjeev, you can take up this question.
Myself, ma'am?
We are not able to hear, sir. I think you can take up. Yes, please.
Regarding prophylactic and therapeutic magnesium sulfate, there is no difference in the dose schedule, first of all.
That is what the message we want to give to the audience, whether it is just to prevent the convulsions or whether it is a therapeutic for the eclampsia, the dosage and the regime, the schedule which we are following, it doesn't differ. Only whether you are following the Pritchard's regime or you're following the Zipspan's regime, that may differ. That is what the message is.
Regarding these two regime, Pritchard and Juspan, the Juspan regime, the IV dose regime is beneficial because the total dose is much less with Juspan regime. It has 29 grams total 24 hours dose. But with the Pritchard regime, the dose is 39 gram, the total dose. So if we consider the total dose of magnesium to be reduced, then better to go with Juspan regime. But obviously we'll have to give IV, and not always we need to monitor magnesium level even if we give IV doses.
Yes.
So Juspan regime can always be given in our setup as well, if we are very much vigilant with the patient regarding the adverse effect of magnesium sulfate.
Perfect. That is what the message to be delivered here. And now we go ahead with Dr. Vidisha. How often will you repeat the investigation for this patient?
This is a severe case, and we'll repeat, ma'am, every twice a week. We can do it.
Yes.
And
suppose she doesn't have any impairment in her parameters. So how frequently will you do the investigations?
If there is no impairment, then we can repeat them after 2 weeks. And
every weekly, at least every weekly.
Severe hypertension.
Even if you don't have any impairment in the liver and renal parameter, it has to be repeated every weekly. But if there is impairment in all the parameters, it is better that you do it every third day. That is twice a week. At what gestation? Now this patient you have brought up to here, and she is otherwise stable. What gestation would you deliver her?
Sneha.
Yes.
Sneha, before you going to deliver, can I make a small point here?
Yes, definitely.
Sanjeev talked very nicely about the total amount of magnesium sulfate administered in Juspan regime as well as Pritchard regime. Okay. But one word of caution that in a hypertensive patient, the Juspan regime always has to be by IV route, intravenous route. And need to be very, very, very careful about the IV fluid administration.
In fact, I wanted to talk about this, that the patient is receiving more and more of the IV fluids, but even otherwise, when you're giving the intramuscular magnesium sulfate, you're trying to see that she's receiving some fluid and the urine output is adequate. Only here, the point to be added here is nowadays you are getting a concentrated solution of the magnesium sulfate.
Yeah, correct.
100 ml. Yes.
Only intramuscular injection also helps, And the second point is that magnesium, if you look at the milliequivalent level of magnesium, which is causing magnesium toxicity, it enjoys a very wide window of safety level. The cardiac arrest happens at 12 and the therapeutic level is 2 to 3. So I think magnesium sulfate is a wonderfully safe drug.
Yes.
And government of India recommends giving magnesium sulfate at the peripheral level, at the village level.
PHC. Perfect.
Yeah.
Yes,
perfect.
Thank you so much, Dr. Ashish. The message very well taken up. And yes, definitely that is what the recommendation, that even when the patient convalesces at the most rural or the remote places, at least the medical officer who is there should give the initial dose at least.
Correct. Absolutely.
Initial dose at least, and then only with proper information, proper communication and documentation, they should refer the patient, preferably with some medical attendant along with the patient.
Absolutely correct. Yes.
Ma'am, one point regarding magnesium sulfate is sometimes we don't mix magnesium sulfate with lignocaine 2%. So that is the reason why magnesium sulfate causes so much of pain during intramuscular route. So that is one of the thing that is to
I
be
think
remembered.
that practice is out of practice now.
That
Nowadays,
becomes, that is not very rightly said, Dr. Ashish. In fact, we have never used lignocaine, while giving. The injection has to be very deep intramuscularly, and you don't have to withdraw the needle unless you inject everything deeply, and you just give a gentle massage. I think that's all. So I personally, in my 30 years of practice, never use lignocaine for intramuscular.
Actually, we have read about this in the textbooks and other things, but then in practice, we rarely do this.
And it is also there in the recommendation, but we don't follow it.
Yeah, I know, but it is not necessary, I think. Okay. And yes, the apprehension that you have made is quite true. That's true.
So, Dr. Mariam, when we are planning now, suppose this patient has, either she is very severe hypertensive, she's got some end organ damage, or we have thought of the situations which can, warrant termination of this pregnancy before term. So how will you optimize the neonatal outcome? I think this we have already covered, but just to repeat, as what steroids and what steroids you want to give and how much?
It is a real challenge to deliver a baby before 34 weeks or before 37 weeks for the lung maturity. Hello? Injection betamethasone 24 milligram in over 24 hours in divided doses. It will help for the fetal maturity of the lung.
Okay.
Fetal lung maturity.
Which steroid you are using in your practice? Which one you are using? Betamethasone or dexamethasone?
Betamethasone at present it is not available in our setup. So I'm using now dexamethasone total 24 milligram.
So FOXY and IFP says that whether it is betamethasone or dexamethasone, it should be 24 milligram over 24 hours. That is how, whether you give 12 milligram with a difference of 24 hours, or whether you give 6 milligrams 6 hours, it doesn't make the outcome the same. Only point of concern here was the betamethasone which is used in the Western countries. The salt propionate is not available in India, and Government of India recommends dexamethasone. Nowadays, even at periphery, you have the dexamethasone vial which is available. So that is what about steroids. But only thing is not to miss this opportunity to give it. You utilize the window of opportunity of at least 24 to 48 hours so that you prepare your baby for the outside world. So you have steroids and magnesium sulfate, which you are already giving as a prophylaxis for eclampsia, that acts as a neuroprotective. And of course, the whether you get the opportunity to wait for this or no, you just give it whatever period she covers, at least 24 to 48 hours. That's going to help the baby, to avoid all these complications postnatally, especially the respiratory distress. So what is your suppose now this is just, I think I would just go ahead quickly with this. This is a part of anesthesia. What type of anesthesia would be your first choice, and what are the risks for general anesthesia?
Actually, I wanted to add something out here also. Maxaf can act both as a neuroprotection for the child also.
Yeah,
If you
that is
give
what we are
Maxaf.
talking about. That is what we have discussed, that yes, whatever you are giving for mother, it's acting as a neuroprotective. Yes. So can you talk on this? What type of anesthesia you should prefer? Suppose this patient requires urgent LSCS, not suitable for delivery. What kind of anesthesia? Whether you would prefer general anesthesia or the regional anesthesia?
The general anesthesia is generally avoided because the respiratory tract, upper airway is edematous. It is very much difficult,
and also the amount of bleeding, it can lead to will be little significantly more as compared to the regional anesthesia. Now this patient actually, whom you are trying to stabilize, you want to take her to term or near term. Now this patient, when you are thinking of giving this neuroprotective, magnesium sulfate has been given, steroids has been given, and now you want to go for the final ultrasonography. Suddenly this patient starts getting severe pain in abdomen, and you find she started getting a little bleeding. When you examine, her blood pressure is now once again 170, 110. Her reflexes are brisk, and you find that uterus is tense, tender, and fetal heart is going down to 110. And that's the very reason you are planning for a cesarean section, because there is some emergency. So what is this complication which has happened? What investigations to confirm this diagnosis?
Yes.
Yeah.
She's having.
Yeah, Dr. Sanjeev. Yeah, you can take up Dr. Alpana and Dr.
Okay.
Sanjeev. You can discuss.
Ma'am, this is clearly going in favor of, not in favor, in disfavor of abruption. So we'll have to deliver as early as possible. But as the
what single
cervical dilatation,
investigation to confirm?
ma'am,
Ultrasonography.
ultrasonography will do all the thing, and the clinical examination will also favor in diagnosis.
It is.
So
It is.
we'll
in
have to
favor of-
plan for delivery, and as the cervical finding is only 2 centimeter and the head is high up, so it's always better to embark
Yes.
on cesarean section.
So at this point of time, you will send her some
After this,
investigations.
yes,
So
ma'am.
you find that investigations, you have done her coagulation profile, her bleeding time, clotting time is normal, 5 minutes and 8 minutes. Platelet count is 50,000. Fibrinogen is only 150 and her FTP is present. So what is your diagnosis at this time and how will you proceed? You have pituitary and abruptio on one side and you have coagulopathy DIC on the other side.
Yes, ma'am. The patient is also developing HELP syndrome, and so that is an immediate indication for delivery.
What is the indication for HELP here? What investigation is pointing towards HELP?
Platelet count is less than 1 lakh.
Only thrombocytopenia.
And,
fibrinogen is going down and fibrinogen degradation products are present. So this patient is going into
also
DIC.
developing coagulopathy.
DIC.
Yes, ma'am.
She's going into DIC.
So we'll have to arrange for the management for DIC, like we'll have to arrange for fresh frozen plasma, and at least 4 to 6 units of fresh frozen plasma has to be arranged. Along with that, we'll have to also go for fresh blood, and definitely if the platelet is going down and down, then we'll have to arrange
What
for
about
platelet as well.
what about the baby inside? Whether
Ma'am,
you'll
there
do
is
cesarean section first or you'll arrange for the blood and blood products first?
No, ma'am, we'll have to deliver as early as possible, keeping all the
So you have to do everything simultaneously.
ICU management, CCU management has to be there, and CCU bed facilities has to be there. So all the intensivists and anesthesiologists, they have to be informed regarding the future eventuality. And after requisition and of fresh frozen plasma and other blood thing, then we'll have to go for cesarean section and delivery as early as
So
possible.
you have to work, you have to work it as an emergency or to call for help and keep all your, it should be a multidisciplinary approach. Your anesthetist, your physician, your intensivist, your neonatologist, and of course your blood and blood bank. Everything has to be in coordination. It has to work simultaneously. You have to arrange for the operation theater and everything, and you have to arrange for blood and blood products, and you have to take the patient for cesarean section because you have to save the baby as well as the mother. So everything has to go simultaneously. So how do you diagnose the DIC? I think we will move very quickly and we should end this discussion now. What is DIC score, if anybody can talk about this? You have various parameters here, the platelet count, the fibrinogen, fibrinogen, and the FDP degradation products, the D-dimer, etc., and of course the prothrombin time. So all these parameters are taken into consider. If the score is more than 5, then it's a overt DIC. If it is less than 5, then it is a non-overt DIC. Of course, we have to manage it. The management doesn't differ whether it is overt or occult DIC. We have to make sure that the patient comes out of this DIC. So whatever blood and blood products are necessary, that has to be arranged. And of course, we have to deliver her at the earliest, and that is not the end of it. Crisis is integral to human life. Those who timely and appropriately counteract it will survive and succeed. That is what Gita says. So we don't have to forget that this patient who has coagulopathy, just delivering the baby will not sort out the problem. She will land up into postpartum hemorrhage, and you have to be very vigilant on this. We have to work actively, go for prevention of this pph, and of course keeping in mind the hypertension, which drug is to be used, not to use the ergometry. Of course, you have to use carbetocin and oxytocin, and you have to use other oxytocics as well. So you have to take care of the patient as a whole, not to forget what complications she can land up into. As Dr. Ashish has very rightly pointed out, even the preload has to be less. Even you are going for the regional anesthesia, even the intraoperative, the fluid should be very, very strictly monitored. And if at all you require giving these fluids or maybe blood and blood products, you may have to go for invasive monitoring. So I think with this, we just go to conclude this. As we have talked about, prediction, prevention, and preparedness is the key to success. Low dose aspirin and high dose calcium and vitamin D, these are very effective and protective. As far as hypertensive disorder of pregnancy is concerned, strict bed rest or restriction of the dietary salt intake is not recommended for the prevention of PIH or improving pregnancy outcome. The use of corticosteroids for the fetal lung maturity is very, very helpful, definitely, but it is not recommended for HELP syndrome. And of course, the antihypertensives, when to start, we have a consensus that it should be started with 140 by 90 millimeter of mercury. Of course, oral labetalol is the first drug of choice as far as the non-severe hypertension is concerned. But anytime the patient has alarming symptoms, signs, or any impairment in the renal or liver function, her diagnosis goes to severe hypertension. And for that, we have to go for the oral nifedipine or intravenous labetalol as per the indication and contraindication for that particular patient. So you have to individualize the management. Prophylactic and therapeutic, the dose of magnesium sulfate and the regime followed remains the same. Of course, Pritchard's Maxwell regime is the time-tested regime, but as we all are, worried about the fluid overload, we have to be very, very cautious as far as the fluid management is concerned. And as I have already suggested, maybe in some of these cases like this, we may have to go for invasive monitoring like central venous pressure. So with this, I thank all the panelists. I thank first of all the Bengal Gynae Society and Dr. Bhaskar Pal and Dr. Sita Ramamurthy Pal in particular, and of course the President Dr. Moshami and Dr. Jaita for giving us this opportunity. I thank my very wonderful panelists for their active, interaction and active participation in the panel. Very, I would say, very useful inputs from all of you. And I take this opportunity humbly to seek all of your blessings and support for my candidature as FOXY Vice President West Zone. And the elections, the voting will start from 1st of August, 1st to 10th of August. It will be online. And from West Zone, we have 2 posts. I request one of your 2 votes as your precious vote for me. Thank you so much. Over to you, Sita. Any comments
Thank
from
you, madam. Thank
any
you.
faculty, anybody?
Any last minute comments?
Yeah, it was a
I think,
wonderful.
can I make a comment here, Sita?
Yes.
Actually, there was a discussion. I think Ram was not audible properly, so we couldn't hear him. Yeah. The question was whether the intravenous labetalol can be combined with oral labetalol or not.
Yes, that question I am raising. Hello.
I know. Actually, we have been doing this for quite some time now, and the logic is that intravenous labetalol can safely be combined with oral labetalol, and and the idea is that when the intravenous labetalol, you have to end somewhere because there is the end point of intravenous labetalol. That is 300 milligram. And by that time, the oral will catch its action. Anyway, the drug is in the system. And I think the controlled reduction in the blood pressure is very, very crucial in such cases. And thank you, Sneha, for nicely discussing hypertensive urgency and hypertensive emergency. So these are the 2 important issues that we must discuss in clinical management of the cases.
And whenever there is some amount of urgency is there, we should be logical with the administration of the antihypertensive. And it's a good practice to combine intravenous and oral labetalol together. There's no problem about that. Yes, Ram, you want?
Thank you.
Ram,
Actually,
you
I
want
wanted to this actually.
Oh, okay.
The actual start oral labetalol, though it is not written in the guidelines.
Yeah.
Yes.
So I have a doubt here that so what is it the same dose of oral labetalol we give or is it a different dose that we combine with IV?
Actually, labetalol, whenever you start orally, always the initial dose is 100 milligram twice daily, because you never know how much sensitive the lady is to the dosage of labetalol. So you can increase the dose labetalol over a period of say 30 hours or 24 to 30 hours. But then you should never start with doses like 300 twice daily or 300 thrice daily. You should not do that. And therefore, the initial dose of labetalol should be 100 milligram twice daily and gradually escalated to 1200 milligram. But I have seen a lot of people don't go up to 12 milligram. This is actually Sivai's regime. Vaha and Sivai spent his lifetime over hypertension management. And 1200 milligram is the finishing dose. And toxic dose is 2400 milligram. Nobody touches the toxic dose. But 1200, I think, easily achievable. And then after that, you add nifedipine deterred, if it is not controlled.
Any comment from Dr. Basab? Yeah, I could see him actually. Basab had just logged out, I think.
Okay. Thank you, Sneha, and all the best for your future and the election. We wish that you come out successful. And as Bhaskar said, you will come out in flying colors. I'm sure about that. Okay. Thank you so much.
Thank you so much for all your blessings and best wishes. Once again, I have already requested, and I take this opportunity to request all of you. Thank you so much.
You have been a very, very hardworking chairperson. I have seen that. And coming from a small place like Yavatmal, it was not easy. Okay. So all our best wishes with you.
Yes. All our best wishes with you, madam.
Sir, thank you so much for all your support. Thank you. Thank you so much.
Yes.
Thank you, ma'am.
For organizing this. And again, best wishes. All our support. Thank you.
Thank you so much. Thank you, Dr. Mashmi.
Thank you, madam. Thank you.
Dr. Javita,
Thank you.
and thank you, Dr. Sanjeev, Dr.
Yes, ma'am.
Diksha, Dr. Mariam,
Thank you, ma'am.
Dr. Alpana. Thank you so much.
Thank you. Thank you. I thank all the faculties for taking the time out and joining and giving the valuable inputs. Thank you,
Thank you,
Ashish,
Sita, for
your
that
talk.
excellent, exhaustive, elaborative lecture.
Yes.
An excellent
Thank
lecture. I wish I could record it.
Thank you, madam.
Yeah, we will have the recording.
For the entire program.
Thank you, MOGS and BOGS, for giving me the opportunity to stay here. Thank you.
Thank you so much. Thank you, all of you. Thank you. Good night. Bye-bye.
Good night, ma'am. Bye-bye.
All the best. Bye. Good night.
Bye-bye.
Bye.
Good night, everybody.
Sir, good night, sir. Good night, sir. I request all of you to, pass your word to your members for
Yes.
Thank you, sir.
Yes, ma'am.
Thank you.
Okay.
Bye-bye.
Thank you, ma'am. Bye.